Assalamu alaikum wa rahmatullahi wa barakatuh. Once again, I'd like to welcome you to our second revision session for the endocrinology course of the full semester 2023. A quick reminder of the rules by which we abide during the meeting. As I said, please keep your microphones mute at all times for the sake of background noise and echoes. And whenever you want to ask a question or you want to make a comment, you can unmute yourself and talk. But please don't talk, all of you, at the same time so that I can hear who is saying what. All right. The next thing is I would like, of course, all of you to open your video cameras so that I can see you like you see me, but I think it will affect greatly the bandwidth of our call today. So I prefer that whenever you want to talk, you can unmute and open your video camera so that I can see you. The next thing is I noticed that some of you have written like Dr. Mona's autopilot. I don't know who this is, so please can you write your name in full, or if you cannot do it, please write it in the chat because I'm taking attendance. Microsoft Teams is taking attendance, okay? So I won't be able to make out who Mona's autopilot is, all right? Of course, feel free, you are all sitting comfortably at home. Feel free to drink or eat whenever you want to. And if you want a break, please tell me so that I can give you. All right? But if you keep silent, I will assume that you're not tired. I remember I am a human being too, and I get tired too, like all of you, since I'm much older. So whenever you feel tired, please don't be shy to tell me to stop and give you a break. Okay? Any comments? Any suggestions before we start? Okay. So I'm going to start sharing my slides with you. Just tell me, please, whenever you see them. Are they visible to you? Are my slides visible?
Yes, it's visible.
Are they in slideshow or are they still small?
Slideshow.
Great. Are they moving or fixed?
Moving.
Great. So today we are going to tackle, these are the intended learning outcomes of today's session. By the end of today's session, the student will be able to list the symptoms and signs of hypothyroidism, detect the atypical presentation of hypothyroidism in children, young women, and elderly patients, enumerate the symptoms and signs of hyperthyroidism, diagnose the presentation of hyperthyroidism according to etiology, detect the atypical presentation of hyperthyroidism, again in children and the elderly, differentiate the type of goiter in the different causes of hyperthyroidism, diagnose the different eye signs in Graves' disease, very important, describe the different methods of detection of exophthalmos, also very important, differentiate the different types of thyroid nodules, and describe the different imaging techniques in thyroid diseases, particularly thyroid ultrasound and thyroid scintigraphy. Am I going too fast? Just tell me. Am I going too fast? Okay, let me adjust the presentation. I think it's advancing. Yes, manually. Okay. All right. So regarding the clinical features of hypothyroidism, did you see a case, a real life case of hypothyroidism in the ward? Did you see a real life case? Can you please answer me? Can you still hear me? Can you hear me?
Yes, doctor.
Okay. Did you see a case, a real life case of hypothyroidism during the endocrinology course? A simple yes or no will do. But if you keep silent,
Not
Sorry?
in the endocrinology course, but in real life, yes, we have
Okay.
seen, of course, hypothyroid cases.
But I assume not all of you. Yani, who's talking? Let me see. Who's talking?
Mariam.
Dr. Mariam. But the rest of you, what about the rest of you? Does this apply to all of you or just Dr. Mariam? Anyway, in case the rest of you didn't see a case of hypothyroidism, I'm going to tell you quickly about the symptoms. You know, of course, the symptoms are the complaints of the patient, right? The patient complains of feeling tired all the time. They're feeling sick. They have malaise, all right? The patient complains of weight gain, particularly if the patient is a lady. As I mentioned last time, any disease that has something to do with the external appearance of the patient, female patients come running, right? Some patients complain of anorexia, loss of appetite, but this is not common. All patients complain of cold intolerance. In the middle of summer, the patient is wearing all the clothes she has at home and still she's feeling cold. This is a problem. Poor memory. Some patients notice this so as to complain of, others don't. Change in appearance, particularly female patients. And the majority of, thyroid diseases in general, whether hypo or hyperthyroidism, occur predominantly in ladies. So they will come complaining, all right? Depression. Either the patient notices herself that she's depressed, or the family members, the husband, the offspring, notice that, and they tend to bring the mother to the psychiatrist. So this is a strange presentation, right? A good psychiatrist will notice immediately that the patient has manifestations of hypothyroidism, and he or she will send the patient, refer the patient to the endocrinologist, okay? Male patients, male hypothyroid patients can complain of poor libido. What does it mean to have poor libido? Who can tell me? Who can tell me? Can you hear me? If you don't know, just tell me, I don't know, for the sake of time.
Yeah. Hear you, doctor.
Okay, so what is poor libido? What is poor libido?
Decrease in sexual desire?
Yes, yes. Type what is the relation between hypothyroidism and sexual desire? Who can tell me? Is there a relationship or not? Of course, there is a relationship, since I told you among the symptoms, a patient will complain, a male patient will complain of loss of libido. Type, what is the relationship? Or in other words, what is the mechanism? Come on, the exam is 2 weeks ahead. What is the mechanism? I'm sure you have studied that. Who can tell me? Yani, if you don't know, for the sake of time, just tell me we don't know. There is nothing wrong in stating that you don't know.
I don't know.
Type. Dr. Mariam was...
LH والFSH بيقلوا
how do they decrease, or what is the mechanism? Dr. Mona Mukhtar. Because we have another Dr. Mona's autopilot.
بيبقى فيه hyperprolactinemia
We are talking about primary hypothyroidism, okay? What is the difference between primary and secondary hypothyroidism? Who can tell me?
Secondary hypothyroidism, the pathology is in the pituitary.
Okay. Type. In primary hypothyroidism, the pathology is where, Dr. Mariam?
In the thyroid gland itself.
Exactly. Thank you. So, Dr. Mona Mukhtar, back to you. You said that prolactin tends to be elevated in which form of hypothyroidism? Primary or secondary?
Secondary.
In secondary?
Sorry, primary hypothyroidism.
In primary hypothyroidism. Okay. Why does prolactin increase? Who can tell me? Why do
الثايروتروف releasing the hormone دوت بيبقى ليه positive effect على البرولاكتين I think.
Okay, so very good. Thank you, Dr. Ramona Mukhtar. So in primary hypothyroidism, the thyroid doesn't secrete enough thyroid hormones. You know, the thyroid secretes predominantly T4, 80%, and 20% of T3, right? Whenever this happens, there is a feedback stimulation from the thyroid to the pituitary gland in order to increase TSH secretion, right? Not only that, but feedback occurs also to the hypothalamus higher up to increase TRH, thyrotropin releasing hormone. Whenever thyrotropin releasing hormone increases, it will not only stimulate TSH secretion, but it will also stimulate prolactin secretion. Okay, so this is how hyperprolactinemia occurs in cases of primary hypothyroidism. All right, is it clear? Any problems so far? Am I going too fast?
No.
All right, so let's continue. Okay, so goiter type. Why have I put the goiter in another color? Because goiter doesn't occur in all cases of hypothyroidism. What are the causes of hypothyroidism with a goiter? Who can tell me? Who can tell me? What are the causes of hypothyroidism with a goiter? Am I still audible to you?
ممكن لو في iodine deficiency أو حاجة.
Very good. Type iodine deficiency. This causes what? Endemic goiter. Okay. Nowadays, طبعا, after supplementation of table salt with iodine deficiency is less common. Okay. But maybe it may be still encountered in some parts of the world away from the oceans and the sea, like for instance in the Himalaya mountains, in the Andes mountains, in Peru and Chile, in the desert, for instance, in the oasis. Okay, but the most common cause of hypothyroidism with a goiter is what? What do you think? Who can tell? Yes, very good, Dr. Amami. Hashimoto's thyroiditis. Okay. What is the third less common cause of, or least common cause of hypothyroidism with a goiter? Who can tell me? Did you hear of a disease called dyshormonogenesis? Did you hear of that?
Yes.
What is dyshormonogenesis? Who can tell me? We are revising, We are revising, and you're supposed to know this. What is dyshormonogenesis? From the name dys, D-Y-S, dysfunctional, hormone, genesis, formation. So why is the formation of thyroid hormones dysfunctional or disordered? Because there are there may be several enzymatic defects in the pathway of thyroid hormone production. I will not go through them yet. And one particular very interesting form of dyshormonogenesis is a familial form called Pendred's syndrome. Pendred's syndrome, in addition to dyshormonogenesis with hypothyroidism and a huge goiter in the neck, there is also sensory neural deafness. I have seen a family composed of the father, the mother, and 5 children. All of them had huge goiters. They had hypothyroidism and they didn't hear. All right. So they couldn't hear. So they had Pendred's syndrome. Okay. Is that clear? So the important causes of, or the causes of hypothyroidism with a goiter are 3. Iodine deficiency leading to endemic goiter, dyshormonogenesis, which is a genetic form, or congenital enzymatic defects in thyroid hormone production, and the most important is Hashimoto's thyroiditis or chronic lymphocytic thyroiditis. Is it clear? Any problems so far? Any problems?
No, doctor.
Okay, let me continue. Type. The patient also complains of puffy eyes, like we are going to see in the pictures, right? So the female patients, I told you, the majority are female patients. They complain of all the cosmetic problems they have, like dry, brittle, and unmanageable hair, right? Dry, coarse skin. The patient will tell you, I use all sorts of creams, even I put Vaseline on my skin, but still it's very dry and rough, like sandpaper or some foreign. Okay. That the patient complains of arthralgia, painful joints, myalgia, painful muscles. Not only that, but the patient also complains of muscle weakness. Of course, it's written in textbook stiffness as well, but we have never seen stiffness in a hypothyroid patient before, but muscle weakness exists. And this muscle weakness, the patient will not complain or tell you, my muscles are weak. How will the patient complain? Who can tell me? How will the patient complain of muscle weakness? Who can tell me? And mind you, this muscle weakness tends to affect the proximal muscles, the muscles of the shoulder and pelvic girdle. So how will the patient complain to make it easier? How will the patient complain?
هيقول مش قادر يطلع السلم مثلا.
Yes. In order not to forget anything, Dr. Mona Mukhtar and the rest of you, organize it systematically. In the upper limbs, the patient will complain of so and so, and in the lower limbs, the patient will complain of so and so. So let's start with the upper limbs. How will the patient complain of muscle weakness in the upper limbs? Yes, Dr. Mariam, go on.
She would not be able مثلا to comb her hair.
Exactly. This movement, you see, this movement, combing the hair, becomes difficult because there is weakness in the abductors and flexors of the arm. Okay, what else? Very good, Dr. Mariam. What else?
She will have difficulty in getting up from a chair.
Did you finish the upper limbs? Are we done with the upper limbs? She will complain of other things in the upper limbs. For example, if she is standing in the kitchen, okay, cooking something, she wants to bring or put something high up on a shelf above the level of her head. She cannot do this movement because of weakness in the arm muscles, as I mentioned. Again, you know, in the countryside, some women like to put a scarf on their head, and they make it in the form of they tie it in the form of a ribbon like that. She's not able to do this movement. She will ask her daughter or her sister, whoever is living there with her, to do that maneuver for her. Okay? Type in the lower limbs. Dr. Mona Mukhtar, you were telling me the patient is unable to climb stairs, right? Type. The patient, if you ask the patient, the patient may tell you, if you ask the patient, why is it difficult for you to climb the stairs? And the patient tells you, because I have difficulty in breathing. Does that indicate muscle weakness?
No.
Okay, type. How will the patient respond to your question when you ask him or her, why is it difficult for you to climb the stairs? What will the patient tell you? What do you think? The patient may tell you, I have pain in my lower limbs. If you analyze pain, you will discover that it is not pain, but it is rather weakness. The patient will tell you, my legs are very heavy. They don't carry me. Okay. Or they feel like bags of sand. Okay. So this is why the patient cannot climb stairs properly. But what else? What is an important complaint in the lower limbs as well, in such cases? And this is, by the way, not found only in hypothyroid patients, but we encounter this proximal muscle weakness also in hyperthyroidism, in Cushing's syndrome or Cushing's disease. Yes, in primary hyperparathyroidism. Okay, so this is why some textbooks, instead of calling it proximal myopathy, they tend to call it endocrine myopathy. Okay, so what is the third complaint in the lower limbs, indicating that the patient has weakness in the lower limb muscles?
Difficulty to get up from a sitting position.
Yes, yes, very good. Not only from a sitting position, but also from a stooping position, actually, and in acromegaly as well. Last time we mentioned in acromegaly that there is also proximal myopathy, right? So actually, we had a patient, an acromegalic patient. She lived in a small village outside Alexandria, and she had this Arabic toilet, you know, الحمام العربي. Did you see it before? This is like an opening in the floor, in the ground, okay, on which there is a porcelain, a piece of porcelain with an aperture in the middle, where the patient has to stoop over it in order to be able to urinate or defecate, right? So this patient couldn't stoop over this Arabic toilet, okay? So she asked the husband to bring a regular toilet instead of it. And in spite of that, you know, the regular toilet is like a chair. She couldn't rise from this sitting position. She had to climb up the wall. Yani she had to hold something in order to pull herself up from the sitting position. Okay, so this is how we detect weakness by symptom, weakness in the upper and lower limbs. All right, deafness. Of course, deafness is part of Pendred syndrome, like I mentioned, but not all causes of hypothyroidism are due to Pendred syndrome. Tab, why do you think deafness occurs in primary hypothyroidism? Why do you think?
Nerve conduction is affected.
Which nerve? Or conduction of which nerve? You have to be specific, Dr. Mariam. And why does it occur if it is affected? Why does this occur? Who can tell me? Who can tell me? In sorry?
I can't follow you. Can you repeat the question?
Yes, the question is why does deafness occur in primary hypothyroidism, not due to Pendred syndrome? I mentioned that Pendred syndrome is rare, right? It's very rare. It's associated with sensory neural deafness. What about the other cases? Like, for instance, Hashimoto's thyroiditis. Such patients may complain of deafness. Why do they have deafness? Dr. Maggie, you want to tell me? Yeah, Dr. Maggie, can you repeat again, please? You are muted. Unmute yourself, please. Dr. Maggie Ibrahim. Yes.
autoimmune disease ممكن يجي معاه autoimmune disease تاني زي منتنير يعمل deafness.
لا Meniere's disease usually doesn't cause deafness. It causes what? It causes vertigo. Okay? I'm talking about the deafness. Why do hypothyroid patients suffer from deafness? For a very simple reason. You know that hypothyroidism is associated with deposition of mucopolysaccharide material in the body all over, right? This tends to cause the weight gain because this mucopolysaccharide material has osmotic properties, so it can retain water. This will increase body weight. Not only that, but it can also be deposited around the median nerve, so it can cause carpal tunnel syndrome, a mechanism totally different than that through which carpal tunnel syndrome occurs in acromegaly, right? We have discussed this last time, remember? And it can be also the mucopolysaccharide material also can be deposited around the vestibulocochlear nerve, causing deafness. Is it clear? Is that clear?
Yes, doctor.
Okay. Yani always associate things together in order not to forget. And try to ask yourselves about the mechanisms. Don't just memorize. Lastly, coma. طبعا, if coma occurs in a hypothyroid patient, this is myxedema coma. Okay, myxedema coma is one of the endocrine emergencies, and it is a very dangerous one because it has a very high mortality rate. It is written in the literature that the mortality rate is up to 50%. Okay. Actually, I've been working in endocrinology since 1991, probably before most of you were born. During that time, I have seen only 3 cases of myxedema coma, luckily enough, because myxedema coma is very rare. And all cases were female patients. They were in their 60s. Unfortunately, all of them died, right? So the mortality at our unit is very, very high. So it's a crime actually to leave a hypothyroid patient until he or she goes into myxedema coma. Okay? Until here, anything not clear? Now let me discuss the signs. As I mentioned before, the signs are those you detect when you examine the patient. Mental slowness. Let me tell you about the prototype of hypothyroidism. She was a patient in her 60s that I have seen a long time ago. Her name was Al-Hagga Zainab. She came, her daughter brought her to the emergency department. She was sitting on a wheelchair and she was sleeping, putting her head like that on her chest, and she was asleep. The patient looked very pale. She was puffy all over. She had swollen face, swollen hands, swollen feet. In fact, all the body was swollen. She had abdominal distension, and actually she was brought to the emergency department with a diagnosis of ascites for investigation. Okay, so I went and talked to the daughter. What is wrong with your mother? Alf salam alayha. Why did you bring her? She's very sick, like you see. Tell me, when did she start becoming sick like that? She told me several months ago she started sleeping excessively, and she didn't move. Actually, when she was sitting on the sofa at home, she used to sit like a statue. Okay, poverty of movement. You see, poverty of movement. And when she sleeps by night, she sleeps on her right side, but she keeps sleeping on her right side like a log like that until morning. She doesn't turn in bed. All of us, we are able to sit on a chair or on a sofa, but for a long time, right? But usually we move. We can put the right leg over the left leg and so on. We move. And of course, all of us, we sleep on the right side because it is sunnah on Rasul alayhi salatu wasalam, but we can turn in bed while we are asleep, right? Not Al-Hagga Zainab. She had poverty of movement. Okay. Tab, what else? Regarding psychosis and dementia, I couldn't check for that because the patient was nearly comatose. She was sleeping all the time. And ataxia was also not, I couldn't detect ataxia because in order to detect, you need to ask the patient to walk tandem, heel to toes. The patient was sitting in on the wheelchair and she couldn't move, okay? So I couldn't check possibly for ataxia. طيب. The next thing I did, I tried to talk to the patient herself. Let me talk to the patient. اسمك إيه يا حاجة? The first thing that happened is the daughter immediately told me, no, please raise your voice. My mom is deaf. She doesn't hear. Okay, deafness. So it can be a symptom. The patient can complain of it, or it can be a sign. Since when did she become deaf? After she became sick. Okay, this is a red flag, another red flag. So I put my mouth near to the patient's ear and I raised my voice. اسمك إيه يا حاجة? What happened is actually the patient's response was very slow. You know, imagine you are deeply asleep and somebody wakes you up. How would you look like? You would open your eyes and you are confused. You may not look at the person who woke you up. Okay, and you may not respond properly. This is exactly what happened with Al-Hagga Zainab. It took her like 5 minutes, for instance, to open her eyes, but she wasn't looking at me. She was looking somewhere else. And then a lot of time passed before she told me, listen to the voice, Zainab, and she fell asleep again. So I noticed her voice was, so she had mental slowness, okay? Mental slowness. I noticed that the voice was deep and it was harsh. So I asked the daughter, is this your mom's voice? No, it changed. When did it change? It changed after my mother got sick. Okay, you see the associations, and the lady had, Hagga Zainab had periorbital edema. She was swollen actually all over the face, but the periorbital edema was very evident. Okay, and she had loss of eyebrows. She was wearing a veil, but from under the veil, I could notice that her hair was very dry and thin. And actually, she had areas of alopecia. Okay, so I asked her daughter again about her mother's hair. What about your mom's hair? She said, it keeps falling off. Whenever I comb her hair, it comes down in large amounts. Okay, and the patient's skin was very dry and rough, like sandpapers. There were some form. And the patient had mild obesity. Actually, she had abdominal distension, and she was referred for the ER with a diagnosis of ascites. Okay. Now, goiter I have put in between brackets. Why? Because it is only seen in endemic goiter, in Hashimoto's thyroiditis, and in dysharmonogenesis. Hagga Zainab didn't have a goiter. Okay. So what is this peaches and cream complexion? What are peaches? Who can tell me? If you read in an English or in an American textbook, you will find this expression. This is why I wanted to explain it to you. What are peaches and what is cream? Who can tell me? Who can tell me? Peaches يا جماعة. What are peaches? Huh?
الخوخ يعني.
الخوخ. أيوة صحيح. خوخ. Type. This is a fruit. What is the color of peaches? What color are peaches?
Orange red كده.
Exactly. Orange, orange, yellow in color. Okay. Type. If you imagine, if you are preparing peaches with cream, cream is white in color. What is the color that you obtain? How is this color? How does this color look like? Peaches and cream. How does it look like? Come on, it's easy. Peaches, when they are mixed with cream, what color would you obtain? Pale orange yellow color. Top. What does this have to do with the complexion? You know, the Caucasian race, هم الناس البيض يعني خواجات, they have a pink complexion, right? When they are healthy, they look pink in color. Okay. Type. Once they develop hypothyroidism, they tend to assume this peaches and cream complexion. They become pale orange yellow in color, like I'm going to show you in the pictures after a while. Why does this occur? Who can tell me? Why does the skin turn pale orange in color? Who can tell me? Sorry?
Hypercarotenemia.
Exactly. Very good, Dr. Maggie Ibrahim. Why does hypercarotenemia occur in hypothyroidism? You have to ask yourselves always, why? What is the mechanism?
Vitamin A decrease.
Vitamin A what? Decreases. How does that cause hypercarotenemia? What is the precursor of vitamin A, Dr. Amona Mukhtar? Dr. Mona Mukhtar, what is the precursor of vitamin A?
Retinol.
No, it is beta-carotene. Beta-carotene. Type. We consume beta-carotene in the diet. It is present in all orange colored food items like carrots, for example, like cantaloupe, like mangoes, like the yellow and the red bell pepper, الفلفل الإضالية الملون ده. اوكي خلاص. So beta carotene is pro vitamin A in the body. Through enzymatic reactions, it is changed into vitamin A. This needs enzymatic reactions. خلاص. طيب in hypothyroidism, the basal metabolic rate is slowed down, and all enzymatic reactions occurring in the body are equally slowed down, including the conversion of vitamin A, of beta carotene into vitamin A. So this is the basis of hypercarotenemia. Okay, the beta carotene accumulates in the body, and the level increases in blood. Hypercarotenemia, emia is for blood, and it will be deposited in various tissues, including the skin and subcutaneous. This is what the basis of the color, the pale orange yellow color in the face. Not only that, but also in the palms, like I'm going to show you in a minute. Okay, is it clear?
Yes.
Okay, fine. Of course, peaches and cream complexion is not seen in patients with dark complexion. Like, for instance, most Egyptians, they have a skin color or a skin tone that is amhi, okay, or bronze in color. And the persons coming from Aswan or from Nuba, they are dark in color, like our African persons, and the persons from African nationalities. Okay, so in those you can maybe detect the pallor, but not the peaches and cream complexion. But I'm just mentioning it so that if you read it in a textbook somewhere, you don't get perplexed what it means. And of course, in Egypt, we have also some fair-skinned persons, particularly those coming from Mansoura and so on. All right. So you see, can you see the picture? Can you still see my slides?
Yes,
Can you see?
doctor.
Okay, so this is a middle-aged lady with gross hypothyroidism. You notice she has a swollen face and a swollen neck, and you see the facial features of this lady have become coarse. But of course, it's totally different than the coarsening of the facial features seen in acromegaly, as I have shown you last time. So she has periorbital puffiness, you see, and she has this apathetic look. She looks sleepy, right? This is what we call apathetic look. And here the nose appears swollen, the lips appear swollen, the tongue is enlarged, okay? And she has this peaches and cream complexion. You know, her color appears orange, yellow in color. And she looks also pale. The peaches and cream complexion is evident on the cheeks, but the rest of the skin, particularly over the forehead and on the nasal bridge, appears pale in color. Here, the eyebrows are intact. She doesn't have loss of the eyebrows, and she doesn't even have loss of the outer thirds of the eyebrows, okay? This indicates that not all hypothyroid patients have all the signs that I have mentioned, right? So you have to pay particular attention. And also the scalp hair is, you see, dry, brittle, and poorly managed, as if she has just waken up from sleep and came to see you without combing her hair. This is how it looks like, right? This is another lady, middle-aged lady, with a typical peaches and cream complexion. Of course, she is of the Caucasian race. You see, كأن كل خد عليه خوخة. عارفين الأغنية؟ كل خد عليه خوخة. This is exactly how it looks like. You see, the rest of the skin appears pale, yellow in color, but her cheeks and nose have the peaches and cream complexion. And of course, the face is swollen, the neck is swollen. She has periorbital puffiness. Again, she has this apathetic look. Here, if you look closely, there is loss of the outer thirds of the eyebrows, particularly on the left side. You see, the right is more intact, but the left is missing. And the scalp hair appears also dry, brittle, and poorly managed. Anything not clear so far? Am I going too fast? Huh? يا جماعة ردوا عليا.
No, doctor, it's fine.
Okay, fine. So let us continue. طيب. What about the rest of the signs? You can, if you measure the blood pressure of the patient, it depends. You will find mostly hypertension. Okay. طيب الحاجة زينب, since she had impending myxedema coma, had low blood pressure. So in myxedema coma, you will find low blood pressure. All right. Hypothermia. This means that when you try and measure the temperature of the patient, the thermometer will not measure. خلاص. حاجة زينب, I tried to measure her temperature. Actually, the thermometer read 35. It didn't measure anything. Hypothyroid patients may present in heart failure. Okay, they have, of course, bradycardia, slow pulse. The Hagga Zainab had a pulse rate of 45 beats per minute. Okay, hypothyroid patients, they may have pericardial effusion. Actually, Hagga Zainab, she had anasarca, she had pericardial effusion, bilateral pleural effusion, mild, and she had ascites. Actually, I told you she was referred to ER with a diagnosis of ascites for investigation. Okay. Myotonia, this is not commonly seen, but it's written in textbooks. Muscular hypertrophy, again, this is not common, but what is common is proximal myopathy. This means that if a hypothyroid patient didn't complain of muscle weakness in the symptoms, you as a physician, you have to examine the muscle power of the flexors, the extensors, the abductors, and the adductors of the shoulder and pelvic girdle muscles. Okay, is that clear? In addition, in the nervous system examination, you will find a delayed ankle jerk relaxation time. Why? Because the deep tendon reflexes are slowed down. I will show you a video on how to elicit a delayed ankle jerk relaxation time. This is very important. Okay. Of course, you will find cold peripheries, hands and feet. Hagga Zainab, she was cold all over, not only the hands and feet, but the whole body because she was hypothermic. Okay. Carpal tunnel syndrome, like in acromegaly. Okay. So the patient may not complain of anything suggestive of median nerve entrapment. So in that case, you have to do all the tests, the Phelan's and Tinel signs in order to detect presence of carpal tunnel syndrome. Of course, edema, and pallor. All right, these are important signs. Okay. Now let me continue the clinical features and then I will show you the videos that I was telling you about. Now the classic picture of a slow, dry-haired, thick-skinned, deep-voiced patient with weight gain, cold intolerance, bradycardia, and constipation makes the diagnosis very easy. Okay, but unfortunately, not all cases present like that. Milder symptoms are usually more common, and so they are hard to distinguish from other causes of non-specific tiredness. And in fact, many cases are detected on biochemical screening by doing the thyroid function tests. Okay? Some particular difficulties in diagnosis may arise in certain circumstances, like for instance in children. Children with hypothyroidism, they may not show the classic features that I have discussed with you earlier, but they often present with a slow growth velocity or short stature. They have poor school performance, and if they present peripubertal, they may show arrest of pubertal development. So before working up any short child for short stature or delayed puberty, you have first to do thyroid function tests to exclude hypothyroidism as a possible cause. Okay? Young ladies with hypothyroidism, they may not show obvious signs. So hypothyroidism should be excluded in all patients with oligomenorrhea or amenorrhea, menorrhagia, infertility, or hyperprolactinemia. Okay, what is oligomenorrhea? Who can tell me? What is oligomenorrhea? What is oligomenorrhea? Can you hear me?
Yes, doctor.
What is oligomenorrhea? And don't tell me this is not endocrinology. Asking about the menstrual history of a female patient is very, very, very important in all branches of medicine. I will tell you later why. But first tell me, what is oligomenorrhea?
It's irregular menses وبتكون الفترات ما بين كل menses يعني prolonged more than
Okay, type. It's okay. Oligo is Greek for decreased. Okay, type. Menorrhea, yani menses, yani decreased frequency of the menstrual cycle. So you need to know the normal frequency of the menstrual cycle of this particular patient in order to detect whether this is oligomenorrhea or not, right? So this is the importance of asking for the menstrual history. Type, what are the items of menstrual history? Let us revise. What are the items of menstrual history? What do you ask about in the menstrual history?
When did the menses first start?
Yes, or the age of menarche. Okay, it may be 10 years, 11, 12, whatever. Okay, what else?
And since then, the regularity of the menses
Type,
comes.
how often? You mean how frequent is it, or how often does it come? Somebody will tell you once every month. Another person will tell you every 21 days. Another person will tell you every 40 days. This is her normal. Okay, normal. Plus the normal frequency. Type, what else do you inquire about?
How many
Duration.
days does it last?
How many days? The duration of the bleeding. Very good. Some will tell you 3 days. Some will tell you 5 days. Some will tell you a week, 10 days. Okay. Type, what else, Dr. Ramona? Dr. Ramona Mukhtar, you wanted to tell me something. What else do you ask about in the menstrual?
Duration.
Sorry?
كنت بقول duration of the menstrual cycle.
Duration. Type. What else? What else do you ask about?
البليد how heavy the bleeding is.
أيوة. The amount of bleeding. Type, how do you ask about the amount of bleeding? How do you ask the patient?
Number of pads per day.
Yes, very good. The number of pads changed per day and whether there are any blood clots or not. The patient, a lady will tell you, my usual is I change 3 or 4 pads per day. Okay. But now, after I became sick, I noticed that the bleeding became more heavy. Now I have to change 10 pads per day and there are blood clots. حتت كده زي الكبدة. This indicates excessive bleeding. Okay. This is what we mean by menorrhagia. Menorrhagia, increased flow of menstrual blood, increased amount. Okay. Type, and hyperprolactinemia, we have known the cause or the mechanism, how it occurs exactly like in men. Okay. And in women, hyperprolactinemia tends to cause amenorrhea, meaning cessation of menstrual cycles, in addition to galactorrhea. Okay, milk secretion from a non-lactating breast. Okay, is it clear? Type.
Yes.
Very good. Now the elderly. Let me tell you why, again, why it is, we have missed a very important point in the menstrual history. You need to inquire about what else? What else? Suppose the patient has amenorrhea. Amenorrhea. Secondary amenorrhea. What do you inquire about? When was the date of the last menstrual period? Why? Why? Why is this important?
Pregnancy.
Pregnancy, exactly. The most common cause for secondary amenorrhea is pregnancy. Okay, so it is very important to ask about it. Let me tell you about an incident that happened in real life. I was working somewhere abroad, and I was seeing a patient with my students in a hospital. This patient was a 35-year-old lady. She was married, she had children, and she presented to the hospital with bilateral loin pain, dysuria, and fever. All right. So she was admitted to be worked up for pyelonephritis. Type, what did they do? They asked for urine analysis. Fine. CBC, ESR, and CRP. Fine. Kidney function tests, electrolytes, sodium and potassium. Fine. But what is not good is that they requested, first of all, they requested an ultrasound on the abdomen, which revealed nothing. So the attending physician did what? He asked for CT abdomen and pelvis. Okay? CT, abdomen, and pelvis. And what happened is a catastrophe. It turns out that the report says there is an 8 weeks viable gestational sac seen in the uterus. Yani, the patient was 2 months pregnant, 8 weeks pregnant, without the attending physician knowing, simply because he did not ask about the menstrual history of the patient. We were like in March, so if he had asked about the last menstrual period, she would have told him it was in January, so he would have done a pregnancy test and found out that the patient was pregnant, and he would not have done the CT. You see, because exposure to ionizing radiation in the first trimester of pregnancy is teratogenic. And the husband filed a complaint against the attending physician, against the hospital, against the medical director, والدنيا اتلخبطت. Okay? So actually, if any of you is going to work in any of the Arab countries, some hospitals have policies and procedures that you have to follow. And some hospitals state that any female patient, even if not pregnant, by the way, before exposing her or asking about any radiological procedure that exposes her to ionizing radiation, you have to do a pregnancy test before asking for it. See, they go so far for medical legal importance. Okay, this is why I'm always stressing that you need to take proper history, menstrual history from female patients. Okay. And of course, if the patient is menopausal, she will tell you the last menstrual period was like 10 years ago, for example. Okay. Now coming to the elderly show many clinical features that are difficult to differentiate from normal aging. Right. So this is why you have to have a high index of suspicion in order to be able to diagnose hypothyroidism in the elderly. Okay. Now let me show you the videos I was intending to show you about the carpal tunnel syndrome. Now, let me start first with the delayed ankle jerk relaxation time. I'm going to share the video with you. Okay. Let me first open it. Just tell me when you see it, huh? Can you see the video now?
Yes.
Okay, let me explain to you first. In the video, there are two patients, okay, or two subjects. Let me say better. The one wearing the gentleman in white is normal, okay. So as you know from the physiology, the muscle action potential is composed of a contraction phase and a relaxation phase. Both of them have equal amplitude and equal duration. All right. Now the other gentleman wearing mauve or brick, he has hypothyroidism. You will notice that the amplitude of the contraction is smaller than normal and the relaxation time is delayed. Okay. So let me show you the video. You see here, contraction, relaxation, contraction, relaxation. Is it clear? Contraction, relaxation. They are equal in amplitude and equal in time. Now look here, contraction, delayed relaxation, contraction, delayed relaxation, contraction, delayed relaxation. Is it clear? You want to see the video again? You will tell me. Okay, I will show you, but you will tell me, do we have to ask the patient to assume this position? Yes. You don't check the ankle jerk relaxation time like we're used to do in neurology. No, this is how you do it. You ask the patient to kneel on a chair, to hold okay, in order not to fall down. And then the both feet are suspended in air. And before tapping over the tendo Achilles, you ask the patient to clench the teeth for positive reinforcement. All right. So if you're using this triangular reflex hammer, and since the tendo Achilles is a large tendon, you use the wide area or the wide part of the reflex hammer to tap over it. Okay, so let me show you again. Contraction, relaxation, contraction, relaxation. Okay? Contraction, relaxation. Both of them are of equal amplitude and equal time. Here, contraction, delayed amplitude, decreased, I mean, and prolonged duration. Is it clear? Is it clear?
Yes, doctor.
Okay, I have told you that, or no, I didn't tell you, but I will tell you now that hypothyroidism usually occurs يعني in middle age, 40s, 60s, like that, okay? Usually patients in that age group, they have osteoarthritis of the knees, so they cannot kneel, they won't be able to kneel on a chair like that. How will you elicit the delayed ankle jerk relaxation time in that case, like in this video? You see? Can you see this video? Can you see this video?
Yes,
Yes,
doctor.
doctor.
Okay, this is a lady. Obviously, she is Indian or Pakistani. Anyway, she is a middle-aged lady. She has bilateral osteoarthritis of the knees. She cannot kneel. So in that case, you ask the patient to stand on the right leg while she is kneeling with the left leg. Okay, and you tap over the tendo Achilles exactly like in the video I have shown you earlier. Let me show you the video. So here he's using a different reflex hammer. He tells the patient to relax, and then he taps, clench the teeth and taps over the tendo Achilles. Here you see the contraction amplitude is decreased and the relaxation time is delayed. All right. This is a typical delayed ankle jerk relaxation time. Is it clear?
Yes, doctor.
And then you ask the patient to stand on the left leg and kneel with the right leg and repeat the maneuver on the other side. You want to see the video again, or shall I continue? Huh?
No, we can continue.
Okay, type. Now let me show you what are the different tests you do to elicit carpal tunnel syndrome, right? These videos they have sound, so I'm going to share the sound as well of the video. Just to tell me if you can hear or not, right? Let me open the video first. Can you see the video? I didn't play it yet. Can you see the video?
Yes.
Yes, doctor.
Okay, can you hear now? Please listen to what he says.
Hey everyone, this lesson is on carpal tunnel clinical signs.
Is the sound audible to you?
Yes.
Yes.
Okay.
And examinations. So carpal tunnel syndrome is due to a tunneling or a compression of the median nerve that runs in this area of the wrist here. So the first clinical test we can perform is called the Tinel's sign. And what that entails is by actually tapping, if we tap over the median nerve, if we elicit symptoms of tinglingness or numbness sensation over the palmar area of the first, second, third, and half of the fourth digit, that's the median nerve distribution. If we elicit symptoms with the Tinel sign of us tapping over the median nerve, that's a positive Tinel sign. The second test is called the Phelan's sign. Phelan's sign is what we call the inverted prayer sign. If we were to hold our wrists together like this for 60 seconds, so you get the patient to hold them like this, put pressure on, basically it's compressing the median nerve like it would in carpal tunnel syndrome. We push our hands together for 60 seconds. If we reproduce the same symptoms of numbness, tingling sensations, again in the distribution of the median nerve along the palmar surface of our hand, first, second, third, and half of the fourth digit. If we reproduce those symptoms, that is a positive Phelan sign as well. So those are the two clinical tests and some of the signs and symptoms of carpal tunnel syndrome.
Okay, is it clear? Is it clear?
Yes, doctor.
So let me show you. Notice that in this video, the physician tapped using the middle finger. Usually we tap using the reflex hammer. If you use the triangular reflex hammer, since the median nerve is a large nerve, you use the wide part of the triangular reflex hammer, like here in this video. Let me show you. Can you see the video?
金妞赛就是在怀疑病人有那个 carpal tunnel syndrome 的时候呢，用扣诊锤在病人的 carpal tunnel 的地方轻轻的敲打。那这个时候呢，病人的神经受到刺激，会感受到他的手指会有麻的感觉。那这个就是一个 positive 的 T 妞赛。
You notice here the physician he was tapping not vigorously. You have to tap vigorously and in a stronger way. Okay, let me show you another video.
Hello everyone, this is Paul from Ortho Eval.
Can you see the video and hear it? Can you see it?
Yes.
Okay.
Pal. And today I want to talk about Tinel's testing, okay? So we're going to be doing a Tinel's at the wrist to help identify if somebody has carpal tunnel syndrome. Now, just a little something about Tinel's. It's important that when you do the tapping, it's nice and steady, nice and even, and you test it on both sides. There are people who will have many false positives with carpal tunnel syndrome, but the way you do it is you have the patient relax, you just expose the anterior aspect of the wrist, and you give just a nice little steady tap. You can use your finger, you can use a reflex hammer, but it's nice and steady. Now, what we're looking for here, I never tell the patient what I'm looking for. I ask them what they're feeling. So if they say they're getting kind of a shooting pain into any of the thumb, index, or middle fingers, or numbness into that area, anything like that, that's positive. That's a positive Tinel sign at the wrist. Okay, thanks.
Okay, so you tap the way this physician is doing, vigorously and evenly. And you, as he mentioned, you have to test it on both sides. Okay, and a very important thing not to do is you don't ask the patient, do you have numbness? Do you have tingling? These are leading questions. Don't ask any leading questions. You just ask while tapping, do you feel anything? If the patient tells you no, خلاص, it's negative. If the patient tells you yes, you ask, what are you feeling? The patient may tell you, I feel numbness, I feel pain, I feel electric shock-like contraction, electrifying pain over my palm, and so on. In that case, Tinel's sign is positive. Okay? Is it clear? Now let me show you another video about Phelan's test.
Hello, doctors. I am Dr. Donald Ozello of Championship Chiropractic in Las Vegas, Nevada. Phelan's test is an orthopedic test for carpal tunnel syndrome. The patient is seated in good posture. Want to make sure that their shoulders are not rolled forward and their scapulas are not retracted. Also, throughout the test, we want to make sure that the patient does not shrug their shoulders. The patient is going to flex their wrist to the maximum amount bilaterally and apply light pressure with the back of the wrist pressing against each other. They hold this position for 30 to 60 seconds. A positive test would be pain, numbness, tingling, or burning along the distribution of the median nerve in the wrist and hand. That distribution is the thumb, the index finger, the middle finger, and the side of the ring finger closest to the middle finger. If these symptoms do occur, it is a positive for carpal tunnel syndrome.
So again, you see, this video demonstrated the proper posture of how to elicit Phelan's test. Like this physician mentioned, the patient should not have their shoulders retracted, or they shouldn't be sitting hunching forward like that. They should be properly seated, like you saw in the video, and then the patient has to maintain this posture for 30 to 60 seconds. Of course, the more severe the condition, the earlier the symptoms will occur after assuming this posture. The milder the condition, the more delayed it is. So it is better to wait for 1 minute, okay, before saying it is negative. Is it clear? What else I wanted to show you in the videos? And as I mentioned last time, we discussed the various causes of carpal tunnel syndrome, didn't we? Remind me, please. Did we review the different causes of carpal tunnel syndrome last time? Because carpal tunnel syndrome is a very common condition. It has endocrine causes, like we mentioned last time, acromegaly, and now hypothyroidism, okay? And it has also other causes, like, for instance, rheumatoid arthritis, diabetes mellitus, even simple obesity, and pregnancy, and occupational, all right? If somebody's working for long hours on the computer and he or she, they are hyperflexing or hyperextending the hands, and they are doing this for many years or months, they may suffer from occupational carpal tunnel syndrome. Okay? Anything not clear, Dr. Maggie? Anything not clear until now? Huh? Type. Now I would like you to help me in commenting on these patients. Can you see my slides? Can you still see my slides?
No.
Type. Can you see them now?
Yes.
Type. First of all, let me ask you, what does the word faces indicate? In other words, what is the difference between face, written F-A-C-E, and faces, written like that, F-A-C-I-E-S? Is there a difference, or are the both terms the same? You can tell me.
Faces special features?
Yes, facial features, exactly, very good. Yani faces, you can say hypothyroid faces, acromegalic faces, Cushingoid faces, and so on. Meaning facial features of acromegaly, facial features of hypothyroidism, facial features of Cushing's syndrome, okay? But when you're in the OSCE station, for example, if you are asked to examine the face of this patient, how would you comment? How would you comment when you are asked this question? What would you examine? In the face. How do you examine the face? This is a general examination, Doesn't have to do anything with endocrinology, General examination, ya جماعة. What do you examine in the face? Who can tell me? Is that such a difficult question? Shall I pick up somebody to answer? Come on, for the sake of time. We're losing a lot of time with your silences. How do you comment on the face? Come on, Dr. Mona Mukhtar, tell me. Yes,
الcolor بتاع الفيس.
طيب, what else? يعني I would suggest you go systematic in order not to forget anything.
الeye.
Yes. What else? Be systematic. يعني first of all, you comment on the shape of the face. Is it normal? Is it rounded? Is it moon face? Is it triangular? Is it elongated? Is the skull elongated? And then you start by commenting on the bony prominences, the supraorbital ridges, whether they are prominent or not, the zygomatic bones, whether they are prominent or not, the chin, whether it is protruded or not, whether there is prognathism or not, okay? And then you comment on the forehead. Is there any frontal bossing? Okay. And then you comment on the eyebrows, whether they are intact or there is loss of the outer thirds or whether all of them are missing. Then you start commenting on the eyes, whether there is any periorbital puffiness or edema at the upper eyelid, the lower eyelid, the eyelashes. And then you comment on the cornea, on the conjunctiva, okay, whether there is any conjunctival chemosis like in Graves' disease, whether there is the palpebral fissure, is it normal? Is there ptosis, drooping of the upper eyelid? Is there lid retraction or is there exophthalmos? And then you comment on the color of the skin, like Dr. Mona mentioned, whether there is peaches and cream complexion, like we have seen, whether there is pallor, whether there is any rash over the cheeks, for example, okay, a butterfly rash. And then you comment on the size of the nose, the size of the lips, the size of the tongue. You comment whether there is any, where there are any signs of angular stomatitis and angular blepharitis, okay? And then you comment on the oral cavity, on the teeth, whether there is bad oral hygiene, if there is gum hypertrophy, if there is any bleeding from the gums, if there is discoloration of the teeth, or if there is any pyorrhea alveolaris, like we commonly see in diabetic patients, if there is any rash inside the mouth cavity, like, for instance, a candidal rash in immune-compromised states and in diabetic patients, whether there is any hyperpigmentation, buccal hyperpigmentation, like what occurs in Addison's disease, like I'm going to show you maybe next time, inshallah. Okay, so this is how to comment on the face, the whole face. Okay, is it clear? So, yes, now I want, I will choose, here on this slide, you can see, still see my slide? Can you still see my slide?
No, I don't.
You don't see it? You don't see the
It
slide?
doesn't appear.
Okay, let me share it again. There. Can you see the slide now?
Yes.
Okay, here you see 3 female patients, okay, of different age groups, an elderly, a middle-aged, and a young lady. And 2 of them are Caucasians, yani from the white race, and 1 is from the black race, okay? All of them share having hypothyroid faces. So one by one, I want, let me ask Dr. Ahmed Mohammed, please unmute yourself and comment on the first lady, the one on the left side. Can you see the slide? Can you still see my slide, Dr. Ahmed? Dr. Ahmed, can you hear me? Dr. Ahmed Mohammed. طيب دكتور علاء ولا عبد المولى ولا آلاء؟ آلاء ولا علاء؟ آلاء. طيب دكتور آلاء, can you still see my slide? Please comment on the first lady. يلا, comment on the first.
From the right to the left.
On the left side. On the left side. يعني أهو. Can you see my my cursor? أهو. This one.
Yes. Yes.
Comment on this one. يلا.
from يعني from the start الهير بتاعها مثلا أنا شايفاه إن هو يعني sparse hair.
sparse بالذات هنا يعني هنا في temporal recession. If you find temporal recession of scalp hair, this is a normal finding in male patients or in male subjects, but she's a lady, right? So this is significant. We can see only the left side, we cannot see the right side because of the angle of the picture. But so here this is significant, you have to comment on it. There is a sparse hair on the temporal recession on the left side. Okay, type. Very good. What else? برضو go systematic عشان ما تنسيش حاجة. Go systematic يعني. What else? What about the eyebrows?
Loss of the I can see the other eyebrow بس اللي هو الليفت ده فيه
لا
yes.
لا ما فيش loss. لا, don't assume this is loss, because how do you detect loss? Like here, you see, if you can you see my cursor? If you run your eye from the medial to the lateral, there comes a point here when hair is missing, but here you can trace it from medial to lateral, so it is a complete eyebrow. Here you are justified to say no loss of the outer thirds of the eyebrows. Okay, يعني, meaning that in the OSCE, not all signs that are written in the textbook are present necessarily in the patient. خلاص? Don't say the signs written in the textbook. Just mention the signs that you can see in the patient. Otherwise, you will lose marks. Okay? Yeah. What else?
Puffiness.
Yes, exactly. Periorbital puffiness, particularly on the right side. You see, as if there is a bag of water in the lower eyelid. Type. What else? What else? What about the nose and lips? The nose and lips. How do they...
هي enlarged nose من قدامي بس
مش هنقول enlarged بقى. بنقول enlarged. We say enlarged in acromegaly, but actually in hypothyroidism it is swollen. نفشة ورمة. Okay? طيب يبقى swollen nose and lips. ماشي. طيب اللوك بقى. اللوك. What about the look? ماله؟
اللي هو apathic look.
apathetic. Yes.
اللي احنا قلنا اللي
apathetic.
هو
يعني هي كأنها نايمة على روحها كده. يعني عينيها مكسورة. She looks sleepy. This is a typical apathetic look. طيب she is Caucasian. Does she have a peaches and cream complexion? What do you think?
to some extent يعني
لا
شايفة
لا, she
اللون
looks بالعكس, she looks waxy pale in color. She looks waxy pale in color. يعني معنى كده not all cases of hypothyroidism present with peaches and cream complexion. Okay. طب is the neck swollen هنا? أو does she have any goiter? ايه رأيك؟ ها؟
لا
مفيش.
لا نو مش شايفة أي حاجة.
Okay يبقى no visible goiter. Okay. Is there anything else you want to add? Anything else you want to add?
هو باين ان هو ثين قوي برضه يعني انا شايفه
اللي هو
ان
ايه؟ ايه ده؟
السكين السكين باين انه من ان هو ثين قوي الفيس يعني
You cannot comment on that, on the thickness of the skin just by looking at this at the face, at the picture. How do you comment on the skin? Can you see my picture? If you see, if you hold a skin fold, yes, over the dorsum of the hand, you will detect that there is thinning out of the skin, or there is thickness, like in obese مثلا. In obese persons, the fold is thick. Okay. But in Cushing's syndrome, for instance, there is thinning of the skin detected by taking a skin fold like that, but not just by looking at the picture. ماشي? Is it clear, دكتورة آلاء? Okay.
Yes, doctor.
All right. طيب, thank you very much. Now, Dr. Alaa Hamid, would you like to comment on the second picture? Can you hear me, Dr. Alaa Hamid? Can you still see my slides? Would you like to comment on the second picture from the left? This lady? يلا. دكتورة Alaa, I can't hear you. دكتورة Alaa Hamid. Dr. Alaa Hamid, I can't hear you. You seem to have a problem with your microphone. Type Dr. Iman Guest. Dr. Iman.
Yes, doctor.
Yes, can you see my slides? Comment on this lady,
Yes.
please. In the middle, the one in the middle. Yeah.
dry hair وكورس كده.
Yes, dry, coarse, and brittle hair. هنا شكله زي ما يكون مقصف كده. What else? يعني you see here and there. What is this? What do you call this?
Lots of hair.
Yes, this is bitemporal recession. Bitemporal recession of the hair, scalp hair. Like here, it was unilateral. Here, it is bilateral. Okay. So what else?
تمام.
What else?
Loss of the lateral third of the eyebrows.
Yes, exactly. It's more evident on the left side. Time. Very good. What else?
Yes. Periorbital edema or puffness of the eyes.
Yes, very good. What else?
Okay. Apathic look.
Yes, apathetic look. Yes, of course, it is less in degree than this patient. What else?
Yes.
What about the nose and lips? Anything wrong with them?
The nose is swollen.
Yes.
Somehow,
and so
يعني.
yes, and so are the lips. The upper lip بالذات يعني. مش كده؟ تمام. طيب. Is the
and she looks pale.
Yes, very good. She doesn't have peaches and cream complexion, but instead she looks very pale. طيب. Does she have a swollen neck or a goiter?
Maybe. هو أنا مش شايفاها قوي بس أنا حاسة إن في يعني
لا بس مش ما فيش لا fullness يعني she's not يعني the neck is not like this lady, but at the same time is not swollen like the necks of the patients I have shown you before. But okay, yes. And you cannot see properly if there is a goiter or not because the neck is somehow covered. In order to detect a goiter, you have to uncover the neck like that completely and like that, and preferably you have to ask the patient to swallow while looking at her neck. All right? Okay, very good. Thank you very much. Thank you. Type, Dr. Farouk, would you like to share with us, Dr. Farouk? Dr. Farouk, would you like to comment on the last patient? Dr. Farouk, would you like to?
Yes,
can you
yes.
see my slide? Yes. Okay. Comment on this lady, please. The one on the right. Go on.
Young lady, I guess, can descend.
Sorry? Can you please raise your voice because I don't hear you properly?
Looks like a young lady of African American descent.
Yes. Or African.
With,
Yani she may not be
or
American, she may be African. Huh?
Yes.
She has what?
She has an apathetic look.
Yes.
Rounded face.
Yes.
She has, I can't tell whether it's a swollen nose or just a genetic makeup.
Yes, exactly. You have to pay very good. You have to pay particular attention when dealing with patients of African descent, whether they are African or African Americans. Why? Because usually, most African people have coarse facial features like this lady, right? So what you do is, if you are in front of the patient, you just ask her, did your face change in any way? If she tells you no, so she has been like that ever since. It's genetic, like you mentioned, Dr. Farouk. But if she tells you yes, then you start asking, how did it change? She will tell you, my nose and my lips became bigger. Only then you are justified to comment by saying swollen nose and lips. Is it clear?
Correct.
And the same applies for the scalp hair, because here you see the scalp hair appears yani dry and maybe rough, okay? Poorly managed. Here you can say it is poorly managed, but usually people of African descent, they have also coarse and rough hair. So also you ask the patient, did your hair change in any way? If she tells you no, it has been like that ever since. خلاص? يبقى don't comment on it. If she tells you yes, how did it change? She will tell you it became dry, it became coarse, it became poorly managed, and then you comment on it. Is it clear?
Yes.
Type. Can you say whether this patient has peaches or cream complexion or not?
It's difficult to elicit.
Yes, exactly, because of the dark color of the skin, right? But what else can you comment on? I mean, does she look pale? Can you comment on that?
Yeah, slightly. She looks pale, I can say.
Yes, of course, not like these two ladies, huh? But she looks pale, right?
Yes.
Okay, Tab, what else would you like to comment on? Does she
Not
have
quite sure if she has periorbital edema or swelling.
It's very mild.
Difficult picture.
It's very mild
yeah.
here compared to these ladies. Yani she has very mild periorbital edema, particularly in the upper eyelid. Okay. Type what about the eyebrows? Anything wrong with them?
I don't see any loss.
Yes.
Eyebrow lining.
Okay, so this is a good negative sign. Here you are justified to say no loss of the outer thirds of the eyebrows, like we have commented on this lady. Okay. Type. What about the neck? Can you see anything wrong with the neck? I mean,
I'll say she's obese. I cannot see. There's the chin and the sternum area is almost.
She has a short neck, right? She has a short neck, so you cannot actually see any goiter, or you cannot see if it's swollen or not. All right. Type. Very good. Correct. Excellent. Thank you, Dr. Farouk. Thank you. Type. Now these are two interesting cases. Again, this is a young lady showing hypothyroid faces, and this is an elderly gentleman with hypothyroid faces. Type. I want بقى who is going to tell me, Dr. Heba Ashur, would you like to comment on the lady, on the girl on the left side? Dr. Heba Ashur, can you hear me? Dr. Heba Ashur. Dr. Heba. Type. Dr. Maggie Ibrahim. Dr. Maggie Ibrahim. Would you like to comment on this girl on the left side, please?
The patient has apathetic look.
Yes, apathetic look. Yes. Okay. What else?
Outer third of eyebrow.
No, they are not lost compared to the other patients. Yani, if you trace the eyebrows from medial to lateral, usually the eyebrows reach until the lateral canthus of the eye. Here it is intact, and here medial to lateral, it's intact as well. Here there is no loss of the outer thirds of the eyebrows. Okay.
In here, scanty, lightly scanty. Not comes the right channels.
Here you cannot actually tell whether it is scanty or not, but what else can you comment on the hair? How else can you comment on the hair?
It's
huh? Huh? Dr. Maggie, all I can hear is noise. Where is your voice? Dr. Maggie.
Hey, Dr. Pardon.
Huh? What is how can you comment on the scalp hair of this young girl? Huh?
No alopecia hair, normal hair.
لا مش normal. هو هنا dry وبصي هنا شايفة يعني poorly managed يعني كأنه هايش كده. Huh? Dry and poorly managed. Okay? But you cannot state whether there is temporal recession or not because هي عندها قصة كده. She's huh? طيب. What else? What about the size of the nose and lips?
Large nose and large lips.
مش هنقول large, احنا قلنا swollen مش كده? Swollen. طيب swollen. طيب does she have peaches and cream complexion? What do you think? Huh? Where did you go? All I hear is noise. Does she have peaches and cream complexion? A simple yes or no would do, Dr. Maggie.
Yes.
Yes, she has. It's not as evident as the very first patient I showed you, but she still has, as if she's putting rouge à joux. كأنها حاطة rouge في خدودها, and on the nose as well. Okay, this is peaches and cream complexion. Okay, but what about the neck? Yeah, the neck is nicely exposed here. Is it swollen or does it show any goiter? What sign is there? What does it show? Huh?
I can't show swollen neck.
Right, but what is in the neck? There is no goiter and there is no neck swelling. But what is this? What is this? Is this a normal neck? ولا اسمه ايه ده? What is this sign?
Supraclavicular fat.
لا. This is
webbing.
Yes, this is very good. This is neck webbing. خلاص. طب what is the يعني webbing of the neck is a sign of which condition? Who can tell me? Turner syndrome. Very good. طب is there a relationship between Turner syndrome and hypothyroidism?
Yes.
What is the relationship?
X isochromosome بيبقى معاه auto immune disease بيبقى معاه thyroiditis وممكن Graves وممكن Hashimoto.
Very good. يعني it can be Turner syndrome, can be يعني patients with Turner syndrome can develop hypothyroidism. Very good. Very good. Okay. طيب. Now, who would like to, دكتورة مين بقى عليها الدور؟ دكتورة مريم, would you like to comment on the gentleman? Please. Can you see the slide?
Yes.
Okay. Yeah, go on.
The patient has a pathetic look.
Yes.
There is peaches and cream complexion.
Yes.
There is loss of the outer third of the eyebrows.
Yes, very good. You see, you can trace the hair until here only. But here it's missing. And here, maybe the whole eyebrow is missing. Yeah. What else?
There is enlarged nose and lower lip.
Yes. What else?
And there is mild periorbital edema.
Very good. So what about the scalp hair? Would you like to say something about the scalp hair?
Well, we cannot, he's a male, so we cannot comment on the temporary recession. It's normal.
هو actually he doesn't have temporary recession only, he is bald مش كده؟ عنده صلع يعني. طيب يعني he may be bald because of the age. يعني old men, most old men are bald. So you don't comment. If you have the patient in front of you, you ask him, did your scalp hair change in any way? If he tells you no, خلاص يبقى هو bald من الأول يعني. If he tells you yes, then you ask him how. How did it change? He may tell you it fell off. يبقى ساعتها you comment there is a alopecia, but there is something else. Would you like to comment on something else on the scalp hair? Even though he is a male يعني.
Maybe the hair seems brittle and
Yes,
dry.
it seems brittle and dry and poorly managed. يعني هو راجل يعني مش هياخد باله إن شعره منكوش. بس so he may not tell you, but you notice that كأنه as if he did not comb his hair يعني. شعره منكوش. Okay? So this is very evident. Okay. طب what about the neck? Is there anything wrong in the neck? What do you think?
I cannot say for sure that there is a swelling or not صراحة.
Okay. Very good. Excellent. طيب, now we have two other patients, a young gentleman and a middle-aged lady. Both of them, they have hypothyroid faces. Now, whose turn is it? Dr. who? Dr. Omneya Mahmoud. Would you like to unmute, please, and comment on the gentleman on the left side? Dr. Omneya, can you hear me?
Yes, doctor.
Can you see the slide?
Yes, I can see the slide.
Go on.
So this patient has an episodic look, we say.
Yes.
There is loss of the outer third of the eyelid.
Of the eyebrow.
Of the eyebrow. Sorry.
Yes, particularly on the left side. The one on the right is intact. Okay, type.
Yes.
Okay.
There is
what else?
swollen nose.
Yes.
Features and the cream complexion.
Yes, very good.
And swollen lips.
Yes, very evident.
I can't see the neck.
The neck is not seen properly in the picture. Yes, not properly exposed. Did you mention about presence or absence of periorbital edema? I didn't hear.
No, maybe slightly.
Yes, he has mild periorbital edema. Okay. What about the scalp hair? Even though he is a gentleman, yeah. What about the scalp hair?
The hair is dry.
Dry and brittle. شايفة هنا كأنه مقصف يعني. شايفة هنا؟
Yes.
What else? What is this? Is this significant?
Well, زي ما قلنا بقى temporary recession. I would ask him if it's a new for him or not.
Yes. And something else. You notice that the temporary recession on the right side is less than that on the left side. Or the other way around. The temporary recession on the left side is more than that on the right side. And this, at the same time, you mentioned that there is loss of the outer third of the left eyebrow, but not of the right. Do you have an explanation for that, Dr. Omneya? What do you think? Why could it be that it is like that? What may be the cause? Did you ever ask yourselves why there is loss of the outer thirds of the eyebrows in hypothyroidism? And why there is temporal recession in hypothyroidism? Why in particular these areas? Can you tell me? Type, let me ask you. When you sleep on the pillow, when you sleep on the pillow, what part of your head or face is in direct contact with the pillow, and the pillow causes friction on that part?
Side of the face.
Exactly. Yani the temporal region and the area of the outer thirds of the eyebrows. Okay. So since in hypothyroidism the hair follicles become weak, they become dry, and they are very friable. So any friction with these areas tends to cause any loss of hair in this particular area. So this means what? This gentleman sleeps more on the left side than on the right side, right?
Yes.
Since there is loss of outer thirds of the eyebrows, of the left eyebrow, and more temporal recession on the left side. Okay, this is why. Type, you will ask me, or let me ask you. So suppose a patient doesn't sleep on the sides, he sleeps on the back. Where would you look for loss of scalp hair?
On the occiput behind.
Exactly, on the nape of the neck. Exactly, on the nape of the neck. Very good. Is there anything else you want to add, Dr. Omnia? Huh?
No.
Thank you very much. Thank you. Type. Dr. Tariq Yusri, can you please unmute your microphone and comment on the lady on the right side? Can you hear me? Dr. Tariq? Dr. Tariq Yusri?
Yes, doctor.
Yes, go ahead. Can you see my slide?
Yes.
Okay, go ahead.
The patient looks apathetic.
Yes.
With puffed face.
Yes, the whole face is swollen. The whole face is swollen, but in particular, if you look around the eyes, there is what?
Around the eye, yes.
What do we call this sign?
Puffiness of the eye.
Yes, or periorbital edema.
Oh, periorbital edema.
Yes, it's more marked on the left side. Okay.
Yes.
What else?
Swollen lips, برضو.
Yes.
Mainly the lower lip.
Exactly. Okay. What else?
Loss of eyelids hair, I think.
لا خلي بالك بقى خلي بالك. Some people have eyebrows that look normally like that. So if you are facing the patient, yani if the patient is in front of you, ask her, anything wrong with your eyebrows? If she tells you no, خلاص, she has been like that ever since. But if she tells you yes, then you start asking, what changed? She will tell you, مثلا, the hair of my eyebrows became less dense, or they became, the hair of my eyebrows is less than before. Then you are justified to comment. Okay?
Okay.
What about the nose?
Swollen nose.
Exactly, particularly at the root here,
the base of the nose. Base of the nose.
Exactly. Top. What about the scalp hair?
It looks dry, messy.
Yeah, it's poorly managed. يعني كأنها
Poorly managed,
يعني as if she was exposed to a fan. نفخ لها شعرها نحكشه. Okay.
Yes.
But I can't say it's very very dry because you see the luster in the picture. يعني. Okay. طيب, what about the neck? Can you comment on the neck?
She has a neck support.
Exactly. So this means that whenever you are facing a patient, male or female, wearing a collar, or a turtleneck pullover, or neck support like that, or even a veil, and you are supposed to examine the neck, you ask the patient kindly to uncover the neck because you want to examine either for thyroid swelling, you want to see the neck veins, you want to check the carotid pulsations, you want to check for the trachea, or you want to check for the neck lymph nodes. Okay?
Okay.
Thank you very much. Thank you.
Thank you.
Now, you see, this lady is middle-aged. She has alopecia. You see, طبعا دي صلعة, and she looks bold. She is a female, huh? Usually ladies are not bold like that, but she has severe alopecia. Not only that, she has also loss of the outer thirds of the eyebrows, and even on the left side, the eyebrows are completely lost. In addition, she looks very pale with peaches and cream complexion. She has an apathetic look and the severe periorbital edema, particularly on the left side, and the nose and lips are swollen. Okay? Very evident. Okay? Now, these pictures I like very much because they show you the same patient while they were healthy and after they became hypothyroid. Now, who would like to comment on this picture? Doctora, let me choose بقى Doctora who did not talk today. Dr. Mariam, would you like to comment? Tell me just the differences, Dr. Mariam.
Yes.
Tell me the differences.
The face before treatment is more swollen than after treatment.
No, this is before. Panel B is before, when she was healthy. Panel A is when she became sick. خلاص? طيب. What is the difference?
Sorry, panel B is before treatment?
Yes, before treatment.
And panel A is after?
No. Panel B is when she was healthy. Yani she was healthy. She was not sick. Panel A is when she became hypothyroid.
Okay.
خلاص?
In panel A, the face is swollen.
Yes.
The nose is enlarged. The lips
swollen.
too.
هنقول swollen. يعني the nose is برضو relatively swollen. And what
the
else?
Lips too. And
yes,
the lips
too exactly. طيب, okay. What
the
about the
right...
neck? What about the neck?
The neck برضو is swollen فيها goiter يعني أو enlargement.
لا, there is no goiter. You cannot say if there is any goiter or not, but you can merely say it is swollen. How do you say it is swollen? Because you see here the folds of aging, where did they go? They are effaced. اتفردت. Why? Because the neck is swollen, but you cannot say whether there is a goiter or not. خلاص? طيب, what else?
I can see the outer third of the right eyebrow is lost.
Yes. Here, of course, the pitfall in this picture is what? Whenever you have a patient who is wearing eyeglasses and you want to comment on the eyebrows, the eyelids, or even the eyes, you ask the patient to kindly remove the eyeglasses so that you can see properly. But here she is like raising the eyebrows. So this is how you can see the eyebrow. But here, the eyebrows are covered by the frame of the eyeglasses. Okay, go on. What
the
else?
look is apathetic.
Yes, yes.
Clearly apathetic in panel A.
Very good, very good. In panel A,
Yes, in panel A.
Yes, very good. In panel B, you see the eyes are like smiling. The eyes are vivid and as if the eyes are smiling. Type, what else?
Also, the hair looks, in panel A, looks brittle, dry.
Exactly.
Maybe more scarce than...
Yes, and poorly managed as well. كأنه منكوش كده, huh? But here you see, it's properly managed and يعني it looks healthy. كمان, you know that the face is swollen just by looking at the nasolabial folds. You see, here they are accentuated under the effect of age, but here, where are the nasolabial folds? They are effaced as well. اتفردوا برضو. Okay, this is how you can detect that there is facial swelling. So what about the color of the skin? Is there any difference?
There's some peaches and cream complexion in panel A,
exactly.
not in panel B.
Exactly. This is the normal pink complexion of Caucasians I was telling you about earlier. And this is the typical peaches and cream complexion. It doesn't only affect the face, but also it affects you see the chest, the neck and the chest, upper chest, as if she has become bronze in color. Okay?
Yeah.
Okay. Anything else you want to add?
No.
Okay. Thank you very much. Now, this is another picture of a patient. She was healthy on the right-hand side, and here she developed hypothyroidism. So who would like to comment and tell me about the differences? Who would like to comment? يلا جماعة عشان نخلص. Who would like to comment? طيب, let me comment. Here you see very evident that the face and neck, they are swollen. Okay, again, the folds of aging are effaced here. Okay, and the nose and lips are swollen also. There is periorbital puffiness, but here the eyebrows are the same. There is no loss of the outer thirds of the eyebrows. They appear the same. And here she has some peaches and cream complexion, but the predominant feature is pallor. If you compare the skin color over the forehead, over the chin, in both pictures, you will find that the patient has pallor. And the hair, you see the scalp hair is brittle, it's dry, and it's coarse, and it's poorly managed. Here it looks more healthy. And of course, she has also a mild apathetic look. Okay, is it clear? Now coming to myxedema coma, I know we didn't revise myxedema coma today, but this is actually how a patient with myxedema coma looks like. This is a female patient, all right? She's not sleeping, she is comatose, and she is obviously being managed in an ICU setting. How do we know? Because there is an orogastric tube in place, the one that is graded, and the orange tube is an endotracheal tube. Why did they put an endotracheal tube? Because the patient is hypoventilating, and so she needs to be put on a ventilator. She has severe facial swelling with severe periorbital edema, more prominent on the right side. There is loss of both eyebrows, and there is a severe alopecia in the scalp hair. She looks very pale, waxy pale in color. There is a swollen nose, swollen lips, and a swollen tongue as well. Right? So this is how, actually, the 3 patients I saw before looked exactly like this patient. Okay? Type. Regarding loss of hair, I mentioned earlier that there is temporal recession. Early, there is temporal recession, and now we know why, because of the friction of the pillow with the hair that is dry and brittle. Okay, but the more severe and the more neglected hypothyroidism is, the more there is hair loss. Hagga Zainab, that I told you about earlier, had scalp hair exactly like that, but she was wearing a veil on top of it. You see, yani you can see the skin of the scalp from in between the locks of hair, and here you can see that the hair is very dry and coarse and يعني poorly managed, حتى مكعبل. This is why the patient cannot comb it properly. Okay, خشن كده ومكعبل زي الليفة. Okay, but mind you, in cases of autoimmune hypothyroidism, they may have an associated type of alopecia of autoimmune nature called alopecia areata. Okay, it may be localized like here. Okay, but it can be also universalis, and it may be also totalis. Like remember, if you watch properly while you're walking in the streets, you may see some subjects who have no eyebrows, no eyelashes, no beard, no mustache if they are male, and no body hair whatsoever. Okay, like the famous actor who was playing the role of the prisoner in the play of عادل إمام, شاهد ما شافش حاجة. Remember في مشهد المحاكمة. Remember, he had alopecia areata universalis. Okay, so always remember, alopecia may be like we have seen before, like that, if the hypothyroidism is long-standing, neglected, and severe, or it may be of autoimmune nature if it is associated with the different types of autoimmune hypothyroidism. All right? And this is vitiligo, البهاق. You see, vitiligo is also has an autoimmune theory in which there are milky white patches, like here over the nape of the neck and over the upper back, and here they are over the knees. This is the normal skin color. So these areas of depigmentation is due to presence of antibodies against the melanocytes of the skin, which carry the melanin pigment. This is localized type of vitiligo. Let me put my charger before my computer off. Okay, so this is a localized type of vitiligo, I mean. This is a localized type of vitiligo, but it may be also generalized. Who is the most famous person you know who had generalized vitiligo? Who can tell me? Who can tell me? Michael Jackson, remember Michael Jackson? He was black in color when he used to sing with his brothers in Jackson 5, but then over the years he suddenly turned all white. It is said that he had generalized vitiligo. Okay. Are you still hearing me? Or is the sound off? Can you still hear me?
Yes, doctor.
Yes, doctor.
Okay. Okay. This is the carotenemia I was telling you about. This is the palm of a normal person. You see, it's all pink in color, similar to your own palm. Now, the white arrow shows a palm that appears orange-yellow in color, and this is another palm. Actually, I have seen a patient like that. A long time ago, when I was an assistant lecturer, still I used to go to the endocrine outpatient clinic and with the residents. So there came this young lady. She was 25 years old. She came from the countryside, and all she was complaining of was, look at my palms, doctor. See how orange they look like? So the first thing that came to my mind is that she may be eating a lot of carrots, or that she may be drinking too much carrot juice. So I asked her, do you eat a lot of carrots? No. Type, do you drink carrot juice? No, I don't like it. Then it occurred to me, since she's coming from the countryside, in the countryside, it is very usual among women that they put henna on their palms and feet, okay? And of course on the hair. So henna is of two types. Henna اللي هي black henna, okay? It is dark brown in color when it is applied, and the red henna, it is red. So I asked her, do you use henna? She told me, no, I never use henna, not even on my hair. What is this? I didn't know, frankly speaking, what to tell my residents. So I asked them to admit the patient, and then we worked her up. We found that she had anemia, normochromic normocytic anemia. And what else? We did also the thyroid function tests, and the TSH was very high. It was like 100, and the free T4 and the free T3 were both low. So obviously she had primary hypothyroidism, and it caused hypercarotenemia, and she came complaining of this cosmetic abnormal orange color in her palms and soles. See, this means that you have always to respect the complaint of your patient, all right? Type. And this is the dry, scaly skin. This is, of course, the skin of a Caucasian patient. You see, it's wrinkled, it's dry, it's scaly. Here's some bleeding as well. And on the right-hand side, this is the typical skin I have seen in Hagga Zainab. Her skin color was like that, okay? And it was scaly like that, like fish scales, and it was very rough. If you put your finger on her skin, it's very rough, like sandpaper. Okay? And now this is congenital hypothyroidism. This is a type of hypothyroidism seen in neonates. Normally neonates should be examined immediately after birth by a pediatrician and specialized in neonatology. He screens for several diseases, among which congenital hypothyroidism. The child appears like that. The face again is swollen, and the neck, and he has coarse facial features with a pathetic look, a periorbital puffiness. There is loss of eyebrows, and the scalp hair is dry and brittle, and the nose and lips are swollen, and there is macroglossia, and the tongue protrudes from the mouth, and the baby, the neonate, has also a pot belly, kirshada, with a persistent umbilical hernia. You know that all or most babies are born with an umbilical hernia, but with time it regresses alone. But in babies who have congenital hypothyroidism, the umbilical hernia tends to persist. Not only that, but if the mother is really very clever and pays attention to her child's cry, she will notice that the voice is hoarse and dry and deep. Okay, not only that, but also normal babies, they usually pass a motion of stool after each feed, whether it be a breastfeeding or by bottle feeding, okay? But the clever mother notices that her child has constipation, so she comes running to the pediatrician. Why is it important to diagnose congenital hypothyroidism very early? Why do you think? Why do you think? Why is it important to detect to diagnose congenital hypothyroidism very early and treat it very early? Who can tell me?
I think because it's we can avoid the mental retardation of
Exactly.
treatment.
Exactly, because thyroid hormones are very important. Very good, Dr. Omnia. Thyroid hormones are very important for the development of the nervous system, okay, of the child. So if neglected beyond 2 years, it can lead to a condition called cretinism, in which there is mental retardation together with, of course, the hypothyroidism. And actually, during my residency, I have seen 2 brothers, and the elder one was like 12 years old, and the younger was 10 years old. Both of them were very short. Actually, they came presenting for short stature, but we noticed that both of them were severely hypothyroid, and they were cretins. They had cretinism. They were mentally retarded. But the parents noticed only that they had short stature. Very unlucky children. Okay, because mental retardation cannot be treated, is not reversible. This is why in recent years they started the screening program for all neonates. They take a blood sample from the heel of the child, min cabo, and they check the TSH level. If it is elevated, then they diagnose primary hypothyroidism, and the child is treated promptly with altroxin replacement therapy. Alas? Okay? Anything not clear until here? Type. Now we shift to hyperthyroidism. Hyperthyroidism is quite the reverse, the opposite of what I've just revised with you. The symptoms include weight loss in spite of increased appetite. Weight loss in spite of increased appetite. Irritability or behavior change. Restlessness, particularly in children. If they are sitting at school in class, the child doesn't sit still like his colleagues or classmates. But actually, the child becomes punished by the teacher, not knowing that poor kid, is sick, he has hyperthyroidism. Malaise again, stiffness again, muscle weakness again, you see, proximal muscle weakness, like affecting the flexors, the extensors, the abductors, and the adductors of shoulder and pelvic girdle muscles. Tremors. Here, fine tremors in the outstretched hands and in the protruded tongue. Choreoathetosis. Now, what is this complicated word? Who can tell me? What is chorea and what is athetosis? Who can tell me? يلا يا جماعة. We are wasting a lot of time by your silence. What is chorea? What is athetosis? Both of them are
abnormal movement.
Yes, they are involuntary abnormal movements. Type, what is chorea? Chorea is jerky, irregular movement, irregular in time and irregular in place. Nobody knows when it is going to happen, and nobody knows in which a group of muscles it is going to happen. This is chorea. But what is athetosis? It is another type of involuntary movement, okay? But here it is twisting in nature. It may occur along the long limb. It may twist like that, or along the trunk, twisting of the trunk. And if both of them occur at the same time, it is choreoathetosis. But this is actually rare, and it is written in textbooks, but I have never seen a patient, a hyperthyroid patient with choreoathetosis. Breathlessness, difficulty in breathing. Palpitations, of course, palpitations here because of the tachycardia or due to the presence of arrhythmia, okay? Heat intolerance. I've seen many patients coming in plain winter, and the wards are very cold in wintertime because they are near to the sea. So this patient was wearing, a male patient I'm talking about, he was wearing a shirt, a cotton shirt, without anything, without any anything underneath, okay? And he was drenched in sweat. And he was fighting with the rest of the patients because he wanted to open the windows in plain winter, and the rest of the patients were all feeling very cold and covered up with the blankets. Itching. This is an important symptom of hyperthyroidism. Okay, thirst, excessive thirst, of course, because of the excessive sweating, vomiting, diarrhea. Actually, you have to ask the patient about the consistency of stools, because diarrhea means increased volume of stools with liquid consistency. But many times you will notice that the patient will tell you, I have like 5 motions per day, but the stools are well formed. In that case, what do I call it? It's not diarrhea, but it's called what? Who can tell me? Who can tell me? What is it called? What is it called?
Hyperdefecation.
Exactly. Very good, Dr. Farouk. Very good. Hyperdefecation. Yeah, excessive. So this is why you need to ask about the normal bowel habits of the patient. How was it before you got sick? If he tells you, masalan, I pass 1 motion of stool per day, and then now he or she passes 5 motions per day, this is hyperdefecation. Okay. Type. Now the eye complaints I have marked with an asterisk and a different color because they are only seen in Graves' disease, like I'm going to show you. Okay, goiter, of course, hyperthyroidism tends to have goiter, unlike hypothyroidism. And I'm going to show you how the goiter looks like in the different causes. Okay, oligomenorrhea, again, oligomenorrhea. Okay, in women. Loss of libido and gynecomastia in men. Again, here and the mechanism is that they have hyperestrogenemia. Okay. Type. Actually, we had a patient, a male patient, who came presenting. He was hyperthyroid, but all he came complaining of was gynecomastia. We searched for the causes of gynecomastia and we discovered that the patient was hyperthyroid. Of course, this is a very uncommon presentation, but you have to put it in mind, because if you don't think of it, you will never be able to diagnose. Okay. Onycholysis. Now, what is this strange word? Onycho is Greek for nail, okay? And lysis is lysis. I will show you the picture immediately after just 1 second. And here, tall stature in children. So, the opposite, quite the opposite of what I have told you in hypothyroidism. Hypothyroid children present with short stature. Hyperthyroid children can present with tall stature. And sweating, okay? You see, this is onycholysis. You see the patient is trying to make a fist. Alas, this is the thumb. This is the index finger, the middle finger. Can you see my cursor? This is the thumb, the index finger, the middle finger, the ring finger, and the little finger. Now, look at the thumb. This is normal. You see the nail is the pink area and the white area, the one that grows and that we cut. Look at the distinction, the pink line between the pink area and the white area of the nail. It is regular here in the thumb. But look at it in the index, middle, ring, and little fingers. It is irregular, and it extends into the nail. Here it extends nearly 2/3 of the nail. Okay, why? Because the nail plate grows away from the nail bed, so there is a space in between the nail and the nail bed. Female patients, again, come running because it looks bad. It's not cosmetic. Look at my fingernails. You will look at her fingernails and you will notice she has onycholysis. But ask the patient, yes, what is wrong with your fingernails? What do you notice? She will tell you. First of all, they look bad, and then I cannot keep my fingernails clean. Why? Because a lot of dirt tends to come in this space, okay? And the onycholysis may be so severe as such that the nail, you can put a wooden stick under the nail, okay? Right. Now coming to the signs, when you examine the patient, you have to look for tremors. They can be seen in the outstretched hands. You ask the finger to spread the fingernails, the fingers, and you look. If you're not sure, put a piece of paper on the back of the hand. You will notice the tremors or the vibrations in the piece of paper. Okay, hyperkinesis. This is what excessive motility. acts quite the opposite of hypothyroidism, poverty of movement. Here you find hyperkinesis. And this is, like I told you, particularly in children, it becomes distressing for the child and for his classmates and for the teacher. So the teacher keeps punishing this poor child. Psychosis, again, the patient with hyperthyroidism may present to the psychiatrist complaining of any psychiatric illness. Okay, tachycardia or atrial fibrillation. If you check the pulse rate of the patient, you will find a heart rate more than 90. Depends, of course, the severity thereof depends on the severity of hyperthyroidism. And even in some patients, particularly elderly patients, they may have different forms of arrhythmias, but the most common is atrial fibrillation. Okay. The patient also has a full pulse, a bounding pulse due to wide pulse pressure because the systolic blood pressure is high because they have systolic hypertension and the diastolic blood pressure is low. Okay, so who can tell me why is the systolic blood pressure high in hyperthyroid patients and why is the diastolic blood pressure low? Who can tell me? يلا يا جماعة, who can tell me? تعبتوا? Are you tired? Are you sleepy?
هو السيستوليك عشان بيزيد الكاردياك اوتبوت والفازودايلاتيشن.
لا, ثانية واحدة. Systolic hypertension occurs because there is what?
Increase في الكاردياك اوتبوت.
طيب, increased cardiac output and increased force of cardiac contraction. Okay. طيب, this will cause increased systolic blood pressure. طب why is the diastolic blood pressure low?
Due to hyperdynamic circulation.
يعني طيب, why does hyperdynamic circulation occur? أو بمعنى آخر, what is the يعني the most important thing? Is it the hyperdynamic circulation or something else? Yeah, Dr. Maggie, you just mentioned there is peripheral vasodilatation. So there is decreased peripheral resistance, okay? So this will cause a decrease in the diastolic blood pressure. So the end result would be a widened pulse pressure or bounding pulse, okay? Anything not clear? Type. There is also warm, there are warm vasodilated peripheries. خلاص? طيب. Heart failure may occur in hyperthyroidism as well. And this is what type of heart failure? اللي فيكو عارف من cardiology. Heart failure is of different types. What type of heart failure is it? Is it low output failure or high output failure?
High output.
Exactly. This is high output heart failure. Type. Now the things that I have marked with a different color and with an asterisk like exophthalmos and ophthalmoplegia, they are only seen in Graves' disease. And similarly, lid lag and stare, conjunctival edema are also seen, and periorbital edema are also seen only in Graves' disease. Okay. And of course, there is goiter. Goiter, it is a sign. It can be of different types, like I'm going to show you in a minute. But presence of a bruit, and this word bruit is French, a French for noise. Bruit is exclusively seen in the goiter of Graves' disease, but not in the goiter of other causes. And of course, you can see weight loss, particularly if you are the attending physician of the patient. You have been following the patient for several months or several years, and you find in your health records that the health records of the patient that he or she, they have lost like 20 or 30 kilograms, for instance, in 1 month or in 2 months. This is طبعا significant. Okay. Type proximal myopathy. Again, proximal myopathy, you as a physician, you have to examine the muscle power of the flexors, extensors, abductors, and adductors of the shoulder and pelvic girdle muscles, right? And you have to look for proximal muscle wasting. There may be wasting of the deltoid or wasting of the quadriceps femoris, right? Onycholysis, again, this can be a sign and it may be a symptom, okay? You have to look for palmar erythema. I'm going to show you in a minute how it looks like. And you have to look for Graves' dermopathy, thyroid acropathy, and pretibial myxedema. Again, these are present only in Graves' disease as a cause of hyperthyroidism. Okay, This is how palmar erythema looks like. You see, look at your own palm. Compare. You see here, what is striking is that the thenar and the hypothenar eminences and the area over the heads of the metacarpal bones are excessively red, while the center of the palm is pale. This is palmar erythema. Of course, there are many other causes of palmar erythema. Who can tell me what are the other causes of palmar erythema besides hyperthyroidism? Who can tell me?
rheumatoid arthritis, liver disease، أي
Not
استروجين زيادة.
بس مش liver disease كده في المطلق. liver cell failure. liver cell failure يا دكتورة ماجي. Okay. طب what else? What else?
أي زيادة، pregnancy, oral contraceptive drugs.
Exactly. Yes. Yes, exactly. Pregnancy or use of oral contraceptive pills. What else? Does CO2 retention cause palmar erythema? Yeah, suppose you have a patient with COPD and chronic respiratory failure. Will you will you find palmar erythema if you examine the patient? Yes, because CO2 retention causes vasodilatation as well, peripheral vasodilatation. Okay? Okay. طيب. Let me continue. This is Graves' dermopathy, you see? This is the skin over the shin of the tibia. It is indurated. It appears like peau d'orange. You know, peau d'orange is again French for orange peel. زي قشرة البرتقانة. The skin is thickened and pits. It has pits and it is purple in color. It appears swollen. If you test for edema, it doesn't pit. Okay, and the same is pretibial myxedema. Now, this term is a misnomer because many of the students are confused. They say it occurs in hypothyroidism because in the past, hypothyroidism was called myxedema, but this is not the case. Pretibial myxedema occurs in hyperthyroidism due to Graves' disease. And as the name implies, it is pretibial. So what is this term myxedema? Because there is pretibial, deposition of myxomatous material in the subcutaneous tissue over the tibia. So this is why it is called pretibial myxedema. Okay? Is it clear? It can be seen in the over the shin of the tibia, but also it may be seen over the dorsum of the foot. So symptomatology, yes, any questions? Anybody asking? Yes. Yes, Dr. Maggie.
myxedema ده permanent حتى بعد التريتمنت. البريتيبيال ميكسيديما ده بيبقى permanent حتى بعد ما بنشيل الثايرويد. شوف patient لسه كتير بيفضل فيهم.
بيفضل. هي نفس الفكرة. It's the same like the eye signs. You see, يعني كون إن البيشنت يعني بقت euthyroid, this doesn't mean that the eye signs and the pretibial myxedema will regress because they are يعني they have to do not with the thyroid function, but they have to do something with the autoimmunity itself. Okay? يعني in other words, you may have a euthyroid patient, خلاص, but the eyes keep يعني the eye manifestations keep progressing and the skin manifestations also keep progressing. Okay? But it doesn't يعني normal thyroid function doesn't exclude presence of exophthalmos or myxedema, pretibial myxedema.
كمان الجريفز اوفتالموبسي بتزيد بعد اصلا الاوبريشن ده.
Yes. واكتر كمان even more after radioactive iodine therapy. This is true. Okay? Very good. Very good observation. طيب, let me continue. طيب, يبقى the symptomatology and the signs again vary with age and the underlying etiology. So the eye signs and the presence of pretibial myxedema and thyroid acropathy occur only in Graves' disease, like I have mentioned. And pretibial myxedema again is an infiltration on the skin, on the shin, essentially occurring only with eye disease, meaning that if the patient with Graves' disease doesn't have eye manifestations, you won't probably be able to detect pretibial myxedema. Okay, so what is thyroid acropathy? This is actually very rare and it consists of clubbing and swollen fingers and periosteal new bone formation, like I'm going to show you in a minute. Okay, and in the elderly, a frequent presentation is with atrial fibrillation or other tachycardias. and or heart failure, often with few other signs. Okay. And the elderly patient may be even looking apathetic, like hypothyroid, as if he or she, yani, they are hypothyroid. So you check the thyroid functions, and surprisingly, you find out that the patient is hyperthyroid. This is what we call apathetic thyrotoxicosis. Okay. Now, clubbing in Graves' disease. You know, let's revise clubbing. Clubbing means, by definition, what? What is clubbing? What is clubbing by definition? What is clubbing, يا جماعة? يا جماعة, is that such a difficult question? What is clubbing?
obliteration للنيل بتأنجل.
Exactly, obliteration of the angle of the nail bed. Thank you, Dr. Mona. Type. Where is this angle? Let me show you. This is a normal finger. خلاص. The line DB, okay, forms an obtuse angle at B with the line BC. Okay, this is a clubbed finger. You see, the line AB and the line BD, they are straight, and the angle here became, it's lost. There is no angle. It is 180 degrees. خلاص. In addition, here there is the second thing is that there are grades of clubbing. يعني في obliteration of the angle, but there are grades of clubbing. What are the different grades of clubbing? You know, who can tell me?
Grade 1.
Yes.
Grade 1 تبقى الانجل 180. Grade 2 بيبقى parrot beak appearance. Grade 3
Yes.
drumstick.
Yes.
Grade 4 drumstick ومعاها rest joint اللي هي pulmonary osteodystrums.
Excellent يا دكتورة ماجي. طيب, let me show you again. طيب, يبقى grade 1 clubbing يبقى فيه obliteration of the angle of the nail bed only. خلاص. This is grade 2 clubbing, and فيه obliteration of the angle. Can you see my cursor? طيب, فيه obliteration of the angle اهي بقت 180 درجة 180 degrees, and there is increased convexity of the nail اللي هي قالت عليها دكتورة ماجي ايه parrot beak appearance, like the beak of a parrot, منقار الايه بغبغان. طيب, grade 3 clubbing includes loss of the angle of the nail bed, increased convexity of the nail, in addition, drumstick appearance. This is grade 3 clubbing. Grade 4 clubbing is exactly like drumstick appearance, but with the addition of broadening of the wrists and ankles. Why? Because there is subperiosteal deposition of new bone in these areas, what we call pulmonary osteoarthropathy. Why? Because it was first described with the pulmonary causes of clubbing. طب, what are the pulmonary causes of clubbing? مين يقول لي? Who can tell me? What are the pulmonary causes of clubbing?
Bronchogenic carcinoma.
Yes. What else? Bronchogenic carcinoma. What else?
Chronic suppurative lung diseases.
Exactly. Suppurative lung diseases يبقى دول بيشملوا ايه? Lung abscess, bronchiectasis, and empyema. Okay? طيب, very good. What else? What else? What other lung diseases can cause clubbing? Dr. Farouk? No.
COPD.
No, COPD doesn't cause clubbing.
Interstitial lung fibrosis.
Exactly. Very good, Dr. Mariam. Interstitial lung fibrosis. And here you will find, in addition to clubbing, you find also central cyanosis. Okay? Type. And of course, don't forget TB. TB, you can put it in the differential diagnosis of all possible diseases. Yeah. Type, what are the cardiac causes of clubbing? You can tell me. Cardiac causes of clubbing.
Teratology de Fallot تقريبا.
Type. Fallot's tetralogy, يعني congenital cyanotic heart disease. Okay. Congenital cyanotic heart disease. And what else? What else? What else? What else? Subacute bacterial endocarditis. Okay, don't forget. Type. What are the GIT causes of clubbing?
Ulcerative colitis.
Yes. وزيها بقى Crohn's disease. يعني you can put it in general inflammatory bowel disease, including ulcerative colitis and Crohn's disease. Type. What else? طبعا, in the past we used to see bilharzial polyposis or schistosomal polyposis. Okay. طيب. Nowadays we يعني schistosomiasis is not frequently encountered يعني. طيب, what are the hepatic causes of clubbing? Hepatic causes. What are the hepatic causes of clubbing? Can liver disease cause clubbing ولا لا؟ ها يا جماعة.
HCC.
لا لا. autoimmune hepatitis على فكرة. autoimmune hepatitis, some cases they develop clubbing, وكمان primary biliary cirrhosis. Exactly. Not في المطلق كده يا دكتور طارق. Primary biliary cirrhosis. You have to specify. Yes, exactly. Primary biliary cirrhosis. طيب. The endocrine causes of clubbing we have mentioned. This is here in thyroid acropathy of Graves' disease. And what else? Some cases of primary hyperparathyroidism, they have pseudo clubbing. Pseudo يعني PSUDO يعني false clubbing. Why? Because there is يعني erosion of the terminal phalanges such that the fingernail appears clubbed, right? But it is a pseudo clubbing, a form of pseudo clubbing. Okay. طيب, the next question that comes to mind is, how do I detect clubbing? There are different tests. The most famous one is the Shamroth sign or the window test. If you ask the patient to put his two index fingers like that on top of each other, in front of each other, you will notice that there is a window, a rhomboid space between both fingers. And it is formed by the angle here and the angle there, right? Type, if the patient has clubbing, first of all, the two nails, they are not adjacent like that here. You see, they are away from each other. And there is no window because there is obliteration of the angle. Okay, this is the very famous test. Another test is that you look tangentially at the patient's finger like that. Okay, you are normal. You have a normal angle. Here is the area of the angle. Can you see my picture? Okay. You put your finger in front of the patient's finger and compare your angle to his angle. If he doesn't have an angle, it will be very obvious. This is the second test, how to test for clubbing. Okay. The third test, how to test for clubbing, this is called phalangeal depth ratio. Normally, in all of us, if you look to your finger, you will find that the interphalangeal depth, okay, measured at the distal interphalangeal joint, is larger than the distal phalangeal depth measured at the area of the angle of the nail bed. But in clubbing, it is reversed. The distal phalangeal depth becomes larger than the interphalangeal depth. Okay, and of course, the best test to test for clubbing is by testing fluctuation. Let me show you a video on how to test for fluctuation. Okay. Let me open the video first. Can you see the video? No, you cannot see it. I have to share it first. The video is very short. Let me first explain. Can you see the video now? Can you see the video now?
Yes.
Okay, let me first explain to you what you see. This is can you see my cursor? This is the thumb of the examiner. This is the index finger of the examiner of the left hand. This is the thumb and index finger of the examiner's right hand. Okay, this is the finger of the patient, and regardless which finger. But look closely. Here the examiner is compressing the area at the nail bed. With the right thumb, with the right index, and he's feeling for fluctuation with the left index. Let me play the video. Can you see? You see? He's compressing here, and it goes up and down. You can clearly see that it goes up and down. There is a spongy sensation. Can you see it? Is it clear? This is how to test for fluctuation. Did all of you see it? Did you understand? Is it clear? Is it clear to all of you? In other words, if you compress كده, اضغطوا كده زي ما أنا بعمل the area of the nail bed. Do you feel any spongy sensation or is it hard? Does it feel hard? Can you see me?
hard.
Okay. طب if it is spongy, this means that there is fluctuation. There is clubbing. Is it clear? ماشي يا جماعة. Is it clear? This is very important. طيب. So this is thyroid acropathy, a patient with Graves ophthalmopathy or Graves' eye disease with pretibial myxedema and with clubbed fingers. This is an even more clear case. You see the patient has a diffuse goiter in the neck and she has exophthalmos with periorbital puffiness. And she has, you see, this is pretibial myxedema seen over the shin of the tibia, shins of the tibia and the dorsum of the feet. And she has thyroid acropathy as well. Okay? So thyroid function tests are mandatory in any patient with atrial fibrillation. And the so-called apathetic thyrotoxicosis in some elderly patients even presents with a clinical picture more like hypothyroidism, like I have mentioned. Okay? And there may be very few signs, and so a high degree of clinical suspicion is essential. All right? Now, in children, the clinical features are different. Children present with excessive height or tall stature, excessive growth rate, more than 5 centimeters per year, behavioral problems like hyperactivity, and they are mostly misdiagnosed as having ADHD, and they may have weight gain rather than weight loss. Why? Because hyperthyroid children, they feel hungry all the time, so they tend to consume a lot of high caloric food items like potato chips, biscuits, and chocolate. So they tend to gain weight rather than lose weight. Okay? Now coming to the goiter in hyperthyroidism. This is a young lady and this is a young gentleman. Both of them have Graves' disease. Here you can see, we cannot see the eyes of the patient, but here we can see the eyes. But look at the neck. This is a diffuse goiter. يعني as if the thyroid gland is having the shape of زي كأن عوامة, huh? With the shape. Yeah, they are not visible? Okay. Right. Sorry about that. Did you see the thyroid acropathy or shall I repeat? Huh?
Oh, please repeat.
No, why didn't you talk earlier? Yani, we're losing a lot of time. This is a case of thyroid acropathy. You see he or she, I don't know. We cannot see if it's a male or a female patient. Eye signs are there in addition to pretibial myxedema and clubbing. Okay. This is even a more clear case because she's a female patient. She has a diffuse goiter in the neck. She has exophthalmos, she has periorbital puffiness, and she has bilateral pretibial myxedema or dermopathy on the shins of the tibia and on the dorsum of the feet. And she has also clubbing. Okay. So regarding the goiter, here I was telling you about the picture. This is a young lady with diffuse goiter in the neck, and this is a young gentleman with a diffuse goiter in the neck. Here you cannot see the eyes of the patient, but here you can see the eyes of the patient. I always say it in Graves' disease, the goiter is diffuse as if you have عوامة يعني a swimming aid with the shape of a thyroid, and you have expanded it in all directions. This is what it means to have a diffuse goiter. Looking at this patient's eyes, do you think he has staring look or exophthalmos? Who can tell me? And who tells me stare? Why? Who tells me exophthalmos? Tell me why. Okay. Shall I increase the size of the picture so you can see better? Let me put it in close up. So can you see now? Does he have staring look or exophthalmos? Who can tell me?
exophthalmos.
Why? Who said that? Dr. Iman? Why did you say exophthalmos?
في retraction في الeyelid, الupper eyelid.
So what? retraction بتحصل مع الليد لاج، مع قصدي الستير، مع الستير. retraction of the eyelid, of the upper eyelid, is actually the cause of the stare. Why did you say exophthalmos and not stare?
دي الوايت ريم اوف سكليرا from upwards يعني اعتقد ده موجود بس مع الاكزوفثالموس.
Who said that?
تكون السكليرا
مين اللي بيقول؟ دكتورة مريم. دكتورة مريم. No. This is the rim of sclera visible between the upper limbus of the cornea and the upper eyelid is a sign of lid retraction. So why did you say exophthalmos? Want to قربته يعني. Look again. Is there a rim of sclera below the lower limbus of the cornea between it and the lower eyelid?
Yes.
And there is a rim of sclera above the upper limbus of the cornea between it and the upper eyelid. This means that what? The whole eye globe has been pushed outside, يعني في exophthalmos. So in exophthalmos, if you look to the patient's eyes in front like that, you will find a rim of sclera above and below the corneal limbus. Okay? While in lid retraction, I'm going to show you that again in details in a minute. While in lid retraction, you are going to be able to see the rim of sclera only above the upper limbus of the cornea between it and the upper eyelid. Is it clear? Huh?
Yes.
Okay. Now let's, can you still see the slides? Huh? Can you still see the slides? Right. Now, this is another cause of hyperthyroidism, toxic multinodular goiter. This is a lady, but she's not as young as the previous lady, right? She has a moderate sized goiter in the neck, but if you look closely, it appears the surface doesn't appear smooth like in diffuse goiter. It appears buccellated, yani as if it's as if there is a nodule here, a nodule there. Can you see my cursor? As if there is a nodule here, a nodule here, another nodule here, and another nodule there, all right? She doesn't have any eye signs, you see? And here on the right-hand side, you can see another neck of another patient. She looks, I think she is a female, I'm not sure. She looks older. Why? Because there are folds of aging visible here in the neck, right? And the neck is enlarged by a larger goiter even, which has a buccellated surface there, and she may even have a retrosternal extension. How do I know? Because you see here there are dilated veins. You see, these are dilated veins. They are raised above the level of the skin and tortuous like varicose veins. Yeah, and as if there is a large nodule here in the left lobe, another very large nodule in the isthmus, and another nodule here and there in the right lobe. So this is toxic multinodular goiter. This is how the goiter looks like. Okay. Have you seen cases of toxic multinodular goiter and Graves' disease during your training? Huh?
Of elderly patient.
Okay.
Elderly patient أكتر.
Elderly patient type. Okay, fine. Type. And this is how a solitary toxic nodule looks like. Again, these are two ladies. There is a marked nodule here in the isthmus. And here there is another patient with a larger nodule in the isthmus as well. The trick here is to be able to define whether this is truly a solitary toxic nodule or it is a dominant nodule as part of toxic multinodular goiter. Why? Because in many cases of multinodular goiter, the many nodules are subcentimetric. They are subclinical. They are detected only not clinically by palpation of the neck, but you will be able to detect them if you do ultrasound on the neck of the patient. Okay? But how can you be sure that this is a solitary nodule by clinical examination? Can anybody tell me? How can you detect that? Can anybody tell you? Tell me? Huh? Who can tell me?
Clinical doctor as in physical examination or?
Yes, by physical examination. Is it possible to determine whether this patient has a single, a toxic nodule, or whether it is part of multinodular goiter?
From physical examination, I'm not sure. I'm not sorry.
I will tell you. You see, normally in all of us, can you feel a normal thyroid? Who can tell me? Is it possible to feel a normal thyroid gland? يا جماعة, a simple question. Yes or no? Is it possible to feel a normal thyroid gland?
No, يا دكتور.
طيب, think again, Dr. Maggie. Both lobes, maybe you're not going to be able to feel them because they are under the strap muscles. But what about the isthmus? Put your finger over the suprasternal notch above it and swallow. Do you feel the tracheal rings, or is there a tissue in front? All of you feel, please, and tell me. In this area, can you see me in the video? Here, palpate in this area. Do you feel the tracheal rings, like here? Or is there a tissue intervening between the tracheal rings and your finger? How is it? How is it, يا جماعة? Answer, please.
We can feel tissue in front.
Exactly. This tissue is what? It's the isthmus of a normal thyroid gland. خلاص? طيب. Coming back to يعني كأن, the answer is yes, you can feel the isthmus of a normal thyroid gland, but not the lobes. Okay? طب, coming back to the solitary nodule. Suppose you feel a nodule here or here, wherever, yeah, in the isthmus, in one lobe only, but you don't feel anything else. This is a solitary nodule. But suppose you feel a goiter, like I have shown you in the previous pictures, a goiter in addition to the single nodule. This is a dominant nodule in a multinodular goiter. Is it clear? And you verify by asking for a thyroid ultrasound. Is it clear now? Does it make sense? Okay, very good. Right. Now, of course, you know this is how to palpate the thyroid. You stand behind the patient, you ask the patient to flex the neck slightly, and you can adjust the flexion of the patient's neck by the thumbs over the occiput. Okay, and this is how, and of course, there is a video, a nice video, but it's a bit long. It's 26 minutes long. We don't have time to watch it together now, but I can put the link for you in the chat if you like, and you watch it. It's very nice, and a very nice video. I like it very much because it was filmed in a university in India, where they show all types of patients you can imagine, whether hyperthyroid or hypothyroid. Okay. Now, coming to the eye signs in Graves' disease, very important. This is the normal eye. You see, the upper eyelid normally covers the upper fifth of the cornea from 11 o'clock to 1 o'clock. Okay. And the lower eyelid is flush with the lower limbus of the cornea at 6 o'clock. Okay. Now, in lid retraction, like we mentioned before, lid retraction, yani there is spasm of the Müller's muscle or the levator palpebris superioris muscle, such that there is a rim of sclera between the upper limbus of the cornea and the upper eyelid. Still, the lower eyelid is flush with the lower limbus of the cornea at 6 o'clock, like normal. Now, a retraction of the upper eyelid may be unilateral, like here. Okay, this is still normal, but here the left eye has lid retraction. Or it may be bilateral, and in that case, it causes staring look. Don't say staring, it is staring. ماشي يا جماعة؟ طيب. And this is the staring look causes the lid lag. Let me show you a video explaining the lid lag. I have a lot of videos, huh? 1 minute. I'm going to open the video first. Where is the video? Here. Okay. And then I'm going to share it. Just tell me once you see the video, please. Where is it? It's not seen. 1 minute. It's not visible. How odd. 1 minute. 1 minute. Can you see the video now? Can you see the video? I didn't play it yet.
No,
Now, can you see it now?
Yes. Yes.
Yes.
Okay. Now, notice, please look carefully. I'm going to the patient. She's a female patient. She's wearing eyeglasses. Plus, the doctor will ask her to remove the eyeglasses. Now, concentrate on the right side, the right eye. Okay. Let me show you. So here, the physician asks the patient to remove the glasses. Concentrate on this eye. You see? You see? There is a rim of sclera already above the upper limbus of the cornea, and it increases when the patient looks down. Why? Because the eye, let's continue. Here, the doctor is testing the extraocular muscle movement. You notice that both eyes are not moving equally. This is what causes the diplopia, particularly on looking up and lateral. You see, this eye is not looking up as much as it should. This is ophthalmoplegia, okay? You see the rim of sclera? Is it clear? Would you like to see the video again? So in this video, you can see the lid lag and the ophthalmoplegia seen in Graves' disease, okay? As I mentioned, ophthalmoplegia normally both, can you still see my picture in the video? You see in normally, both eyes, both optic axes should be parallel in all directions. Okay, looking up and lateral, looking up and lateral on the other side, down and lateral on the other side. They should be parallel on all times. But once one eye starts moving more than the other, ophthalmoplegia is the case. Okay? Okay? So would you like to see the video again to be able to understand what I'm talking about more? Can you still see the video? Can you still see the video?
Yes.
Okay. Yeah, watch closely. It's not moving. Yeah. See, there is a rim of sclera above the upper limbus of the cornea, between it and the upper eyelids. It increases, obviously, when the patient looks down. This is lid lag, okay? Right? Now, look at the extraocular muscle movement. This eye moves better than this eye. The left eye moves better than the right, you see? The optic axes are not parallel, you see? And here, when the patient is trying to look up and lateral, the right eye doesn't move equal to the left eye. This is what causes diplopia on upward gaze. Okay? Is it clear? This is ophthalmoplegia, right? Is it clear?
Yes.
Okay. Let me go back to the slides. Can you see my slides now? Can you see my slides? Yes. Okay. Yes. So this was lid lag. So again, lid lag is due to spasm of the levator palpebrae superioris, which pulls the upper eyelid up. So the lid lag occurs when the patient is trying to look down. The eye globe moves down, but the upper eyelid lags behind because it is spastic. Okay. طيب. So again, the difference between lid retraction and exophthalmos. Okay? خلاص? I think it's very obvious يعني. Huh? طيب. Now, this is a patient with Graves' disease, and she has periorbital puffiness, very evident, you see, bilateral. She has exophthalmos. This is very early exophthalmos. Why? Because if you look closely, you will find a very small rim of white sclera between the lower limbus of the cornea and the lower eyelid. A minute. Here, you see? And there. But there is a very evident rim of sclera above the upper limbus of the cornea and the upper eyelid. So this means the patient has exophthalmos because the whole of the eye globe has been pushed out. She has conjunctival chemosis. If you look closely near the lateral canthus of the eye, particularly here in the left eye, you will notice something red, right? And it's swollen. This is the conjunctiva. A swollen conjunctiva is called conjunctival chemosis, not ecchymosis, but chemosis, okay? Swollen conjunctiva. A normal conjunctiva is a very thin structure or film that covers the sclera, as if it's not there. But once the conjunctiva becomes edematous, it shows like here. So how can you detect it? You just simply, you see the red color in the conjunctiva here. So you try and put your index finger where I'm putting my cursor, and you push the lower eyelid up. You will find that the conjunctiva will become wrinkled. How is that? Imagine you are wearing a blouse with a tight, with tight sleeves. If you try to wrinkle it, can you see my picture in the video? If you try to wrinkle it like that, it won't be wrinkled. Like, suppose you wear a white coat over the tight sleeved blouse, and then you try and wrinkle the sleeves of the white coat. It becomes wrinkled. This is the same principle. As long as the conjunctiva is stuck to the sclera with no edema, you cannot wrinkle it if you push the lower eyelid against it. But once it becomes edematous, there is a space in between, so you will be able to wrinkle it. Okay? Is it clear? Is the principle clear?
Yes.
Okay, great. Now back to the patient. This exophthalmos may be unilateral, like here in these patients. Of course, our colleagues in the ophthalmology department, they see a lot of patients with unilateral exophthalmos, and they have their own causes for unilateral exophthalmos. After they exclude all these causes, they send the patients to us, okay? But it may be bilateral, like in this patient, you see? Very obvious, there is a white rim of sclera, a big white rim of sclera under the lower limbus of the cornea, between it and the lower eyelid, as well as another big white rim of sclera above the upper limbus of the cornea, between it and the upper eyelid. And here, in addition, you find the conjunctival chemosis that I was telling you about. You see, if you put the cursor, if you put your index finger here and you push upwards, this area will become wrinkled. This is the chemotic conjunctiva. And here, chemosis is extensive, not only affecting the lateral part of the conjunctiva, mainly over the, the insertion of the lateral rectus, but it also affects the medial parts of the conjunctiva as well. It's extensive, okay? Now, how do we detect exophthalmos? I have mentioned, like seen in the previous pictures, by looking at the patient up front like that. You will be able to notice a rim of sclera below the lower limbus of the conjunctiva, between it and the lower eyelid, as well as the rim of sclera above the upper limbus of the cornea, between it and the upper eyelid. Okay, but then if you look at the sides, to the patient's eye in side view, you will notice that the eye is bulging. You try and you bring a ruler. You bring a ruler. You try normally in all of us, if you bring a ruler, or even you put a pen or your finger, trying to touch these 3 points, the supraorbital ridge, the cornea, and the maxillary bone, you will be able to touch all 3 points simultaneously. But in the presence of exophthalmos, you will be either able to touch the supraorbital ridge and the cornea, but here there is a big space between the ruler and the maxillary bone, or you can touch the maxillary bone and the cornea, but there is a wide space between the ruler and the supraorbital ridge. Is it clear? Is this test clear? Of course, you ask the patient to close the eye while doing this, so as not to injure the cornea. Unless you ask the patient, please close your eyes. If the patient is wearing eyeglasses, please remove your eyeglasses and close your eyes without closing them firmly, just closing them as if he or she are sleeping. And then you try and put the ruler like that, trying to touch the supraorbital ridge, the cornea, and the maxillary bone. If you cannot do it, this means there is exophthalmos. And of course, there is another test, very interesting. You let the patient sit on a stool lower than your level, and you stand behind the patient, and then you try and look to the patient's eyes in supraorbital plane, like that, right? Normally, you will be able to see only the supraorbital ridge and the nose, and the eyelashes, but not the eye globe itself. This is the normal eye. But in exophthalmos, you will see the eye bulging like the eyes of a frog. Okay, so this is another test. Of course, the best test is to measure exophthalmos using exophthalmometry, and we do this when we want to follow up cases of Graves' ophthalmopathy. You want, first of all, to quantify whether it is mild, moderate, or severe exophthalmos. And then you want to check over time whether it is progressing or regressing. Of course, we don't have an exophthalmometer at the endocrine unit, but we send the patient to our colleagues at the ophthalmology department. Okay? Any problems so far? This is ophthalmoplegia, you see? The patient is supposed to be looking upwards, but the left eye is looking upwards, but the right eye doesn't look upwards. This is another patient with ophthalmoplegia. This patient is supposed to be looking straight ahead. The left eye is looking straight ahead, but the right eye is deviated downwards. And in addition, the patient has also exophthalmos. She has periorbital puffiness, and she has extensive conjunctival chemosis. And this is the imaging of a case with Graves' ophthalmopathy. The imaging is very important. This is a skull, a CT brain at the level of the orbits. Bone without contrast. Bone appears white. So this is the sphenoidal bone. This is the ethmoidal bone with the cribriform plate of ethmoid. And this is the rest of the skull bone. Okay. And this is the nasal septum and the nasal cartilage. And air appears black. So this is air in the nasal cavity and air in the ethmoidal air sinus. Okay. And these are the eye globes. Let me enlarge it so that you can see better. You see, this is the eye, the anterior chamber, and the lens appears somewhat white in color. And the anterior chamber appears grayish in color because it is full of aqueous humor. And this is the vitreous humor. It also has high water content, so it appears grayish in color. And this is the optic nerve. Okay, the white arrows point at the lateral rectus muscle and the medial rectus muscle. The medial rectus muscle and the lateral rectus muscle. And the black structure behind the eye globe is the retroorbital fat. Okay. So here, actually, the eyeball itself is pushed outside. Why? Because increased retroorbital fat, and because of deposition or infiltration of the retroorbital content, as well as the medial and lateral recti with lymphocytes and mucopolysaccharide material. Okay, this is what causes them to swell like that. And all this increases the intraorbital pressure, pushing the eye globe outside. This gives the eye globe a lollipop appearance, زي المصاصة. Okay, ماشي يا جماعة? The imaging is very important. Okay, طيب. Now coming to type 2. Type 2 نكمل. Are you tired? يا جماعة ردوا عليا. Can you still hear me? طيب. Can you still hear me? طيب. We have like less than 30 slides to go. Let me did Dr. Mahabondo explain to you about thyroid ultrasound? ها؟
لا لسه يا دكتور، لسه عندنا محاضرة بس ما خدناهاش.
نعم كان في محاضرة ايه؟
لسه ما خدناهاش.
طيب اوكي I will explain to you يعني let me show you. Okay. So one of the most important imaging modalities for thyroid is ultrasound. Okay. This is how a normal thyroid looks like on ultrasound. It is uniformly hyperechoic. Hyperechoic يعني معناها الإيكو بتاعها أعلى. يعني معناها إيه؟ يعني كأنها these are the strap muscles. شايفين؟ strap muscles هنا اهي. لونها أسود. They look black in color. If you compare the echogenicity of the thyroid to the strap muscles, it appears more white in color. يعني more gray in color. These are black, but the strap muscles are black, but the thyroid appears whiter or grayer in color. So this is the thyroid lobe on one side. This is the thyroid isthmus, and this is the other thyroid lobe. And here, the landmark in the middle is the white structure is what the tracheal ring. Okay? The trachea, يعني you always look in the thyroid ultrasound for the trachea in the midline. In front of it is the thyroid isthmus. On one side is the thyroid lobe, on the other side is the other thyroid lobe. And this is the carotid sheath. Okay? Is it clear? So this is how a normal thyroid gland looks like. Again, the anatomy. The trachea, the isthmus, the right thyroid lobe, the left thyroid lobe, and these are the strap muscles. They appear darker in color. And this is the common carotid artery and the internal jugular vein on either side. Is it clear? The normal thyroid appears hyperechoic compared to the relevant strap muscles. النقطة دي مهمة جدا جدا جدا. Very important to remember. Why? Because in thyroid pathologies, the picture is going to become different. How? This is how the right thyroid lobe looks like. You got the trachea, the thyroid isthmus, and the right thyroid lobe, the right carotid artery, the right internal jugular vein. This is the left thyroid lobe, and these are the strap muscles اللي هم عليهم white arrows. And here you can see the esophagus. The esophagus is to one side, to the left side. How do you know that it is the esophagus and not something else? You ask simply the patient to swallow. You will notice that the mucosa of the esophagus will contract while the patient is swallowing. Okay? And again, this is the trachea, the isthmus, the right thyroid lobe. It appears more echogenic than the strap muscles and the carotid artery. خلاص? طيب, what about the typical sonographic features of Graves' disease? First of all, you find a diffusely abnormal appearing thyroid gland. Yani, you see the isthmus, if you compare this isthmus to the isthmus here, you will find it is like double in size. Yani, and the same applies to the right thyroid lobe and the left thyroid lobe. مش بس كده. يعني it is enlarged and heterogeneous and hypoechoic. يعني ايه hypoechoic? It became blacker, more black than the normal thyroid اللي هي كانت هنا. شايفين هنا كانت more white in color. هنا more black in color. خلاص؟ طب مش بس كده. If you do duplex study on the thyroid parenchyma, you will find diffuse increased vascularity throughout the thyroid gland parenchyma. This is what we call thyroid inferno. Inferno يعني جهنم. As if the whole thyroid gland is on fire. This is the typical thyroid inferno sign seen on duplex imaging. Any problems so far? Am I going too fast? Huh?
No.
Okay, fine. طيب, let me continue. Type, what about the thyroid ultrasound in subacute thyroiditis? You know, subacute thyroiditis occurs due to a viral infection, for example. Okay? Type, the thyroid gland is also enlarged. خلاص? With heterogeneous echo texture. يعني it's not, you see some black areas, some grayish areas, and so on. But obviously it is very enlarged. And Doppler studies, this is concentrating on the right lobe, they show reduced vascular flow. Reduced. It is not normal. It is not increased like here, but it is reduced. These are the typical thyroid ultrasound manifestations or signs in subacute thyroiditis. And of course, if it is early in the disease, it tends to be very tender. Yani the patient cannot tolerate the transducer over the neck because of thyroid gland tenderness. Okay? Is it clear? Any problem so far? Huh? يا جماعة
No,
ردوا عليا.
doctor.
Okay. Type, now coming to thyroid ultrasound in Hashimoto's thyroiditis. Hashimoto's thyroiditis is chronic lymphocytic thyroiditis, one of the important causes of hypothyroidism with a goiter, like I mentioned. Here you notice that the thyroid gland is hypoechoic. Yani if you compare the echogenicity of the thyroid to the strap muscles, you find it decreased. With coarse micronodular, here you can see as if there is a nodule. Here as if there is another nodule. Here as if there is another nodule. Micronodular echo texture. This is the typical thyroid picture, thyroid ultrasound picture in Hashimoto's thyroiditis. Okay, again, here you can see coarse. This is in transverse and this is in longitudinal. You see the coarse micronodular echo texture. This is the right lobe. This is the left lobe. In longitudinal, this is the transverse, and this is the longitudinal cut. Okay, and of course the echogenicity of the thyroid is hypoechoic, and decreased echogenicity. تمام? طيب, again, the dominant feature is diffuse hypoechogenicity. شايفين كأن لونها اسود. يعني the color of the thyroid parenchyma becomes black instead of gray. And it has a lot of black holes inside, indicating absence of thyroid tissue, and some scarring, the white areas, fibrous tissue, and decreased vascularity. If you check with Doppler, and there is decreased vascularity, and there is architectural damage in an overall enlarged gland. يعني في goiter. There has to be goiter. Okay? ماشي? Until here, any problems? Am I going too fast?
No, doctor.
Okay. Type here, as you see, as if the whole picture is black. Where is the thyroid? I can delineate it for you to be able to see it. This is the right lobe. But now, in this stage, the thyroid gland is shrunken. Because why? Because with the inflammation, it is a chronic lymphocytic thyroiditis. With the chronic inflammation, there tend to be areas of regenerating nodules, which cause the goiter, with fibrosis. So the more long-standing it becomes, the more the fibrous tissue, the less the size of the thyroid becomes. Okay, so here it is shrunken, scarred, and shriveled with pseudo. Whenever you read pseudo, this is Greek for false, yani false nodules, as if there is a nodule here, there, and there, but these are false nodules, and scattered fibrous bands in a small gland. The fibrous bands appear white in color, somewhat white. This is the final stage of Hashimoto's thyroiditis, and here the patient has hypothyroidism. Okay, is it clear? Any problems so far? Huh?
No, doctor, it's clear.
Okay. Now coming to the very important topic of thyroid nodules. I'm not sure. Did you have an assignment? Did you do assignments during the endocrinology course?
No, we haven't.
Okay, never mind. So thyroid nodules, don't be confused about this line. This is usually the ThyRads classification according to the American College of Radiology. Plus, they look at thyroid nodules according to composition, echogenicity, shape, margin, and echogenic foci. And they give a score to each one of these. So if the score is 0, this is TIRAD 1. And obviously, it is a benign nodule with no risk of malignancy. If it gets 2 points, then it is TIRAD 2. It is not suspicious, no need to do a fine needle aspiration. If it gets 3 points, then it is TIRAD 3. It's mildly suspicious, so you need to do a fine needle aspiration if the size of the nodule is 2.5 centimeters or more, and follow up if it is 1.5 centimeters or more in size. If it gets 4 to 6 points according to these criteria, then it is a TIRAD 4, which is moderately suspicious. And you need to do a fine needle aspiration if the size is 1.5 centimeters or more, and you need to follow up if the size is 1 centimeter or more. If the score achieved is 7 points or more, then it is TIRAD 5, and it's highly suspicious. You need to do a fine needle aspiration if the size is 1 centimeter or more, and you have to follow up if it is 0.5 centimeters or more. Okay, so now let me show you. This is a very brief discussion for the TIRADS classification. Let me show you the different patterns of thyroid nodules. You see, this is a thyroid nodule, and the black is a cyst, so it's cystic with tissue component, and here it's predominantly half cyst and half tissue. This is predominantly tissue with a small cyst inside, but this is predominantly tissue, solid as well here, but this is transverse. This is more it has a higher AP diameter, anteroposterior diameter, more tall than wide. This is more wide than tall. And here there is a hypoechoic nodule. Let me show you again in more detail the sonographic features according to the American College of Radiology TIRADS classification. The composition. If it's cystic or almost completely cystic, it gets 0 points. If it's spongiform, it gets 0 points. If it's mixed cystic and solid, it gets 1 point. If it's solid or almost completely solid, it gets 2 points. This is as regards composition. As regards echogenicity, if it's anechoic, there are no echoes inside, it gets 0 points. If it's hyperechoic or isoechoic, of equal echogenicity to the surrounding thyroid lobe, it gets 1 point. If it's hypoechoic, it has less echogenicity than the surrounding thyroid lobe, it gets 2 points. If it's very hypoechoic, very black that is, it gets 3 points. Now coming to the shape, if it's wider than tall, it gets 0 points. If it's taller than wide, it gets 3 points. Okay? Coming to the margins, if the nodule has smooth margins, it gets 0 points. If it's ill-defined, it gets 0 points. If it's lobulated or irregular, it gets 2 points. If there is extra thyroidal extension of the nodule, it gets 3 points. I'm going to show you pictures of all that later on so that you can understand better. And if there are no echogenic foci or large comet tail artifacts, it gets 0 points. If there are macro calcifications, it gets 1 point. If there are peripheral rim calcifications, it gets 2 points. If there are punctate echogenic foci, it gets 3 points. Okay, now let me show you some pictures. This is a nodule. This is the trachea. Okay, and this is the isthmus. This is the right thyroid lobe, and this is the left thyroid lobe. Okay, now this is the left side of the isthmus. Okay, there is a nodule in the left side of the isthmus. Okay, and then the nodule appears what? It is hypoechogenic compared to the rest of the isthmus. You see, it appears more black, and inside there is some tissue. Halas? Let me show you a spongiform thyroid nodule. It looks like a sponge. How does a sponge look like? Like this, you see? It has more than 50% of the nodule is composed of small cystic spaces, the black areas. These are cysts. But the nodule received 0 points for composition because it is spongiform and no additional points in the other categories. So this is TIRAD 1. Is it clear? Or are you confused? Tell me. If there is something not clear, please tell me. Is it too complicated for you? Huh? Is it clear?
No.
Okay.
Yes.
Very good. So let me continue. This is a benign mixed cystic, the black area, and solid thyroid nodule. Plus, it got 1 point because it is isoechoic. You see the tissue, the solid component of the thyroid is isoechoic, yani it has the same echogenicity as the rest of the thyroid. خلاص? And it is distributed around the periphery of a cyst, the black area. خلاص? So this is obviously, it got 1 point, so this is TIRAD 2. All right? Now this is a benign colloid thyroid nodule, this one here. Let me show you. It was classified as solid, you see, because it is solid. So it got a score of 2. Although there are some cystic components, the black areas, some cysts. So there is also 1 more point for isoechogenicity. You cannot, this is the rest of the thyroid. It has the same echogenicity for as the rest of the thyroid. So the total point was 3. So this is TIRAD 3. Okay? Is it clearer now to you, the classification, the TIRAD classification?
Yes.
Right. Now this is the white arrows point at this, you see? And let me put the cursor as a laser pointer. This one. This is a benign follicular nodule. It has smooth margins, as you can see by the arrows, you see? And the nodule was assigned 2 points for having a solid composition and 1 point for being isoechoic. This is the rest of the thyroid. It has the same echogenicity as the rest of the thyroid. So it has a total of 3 points. Yani TIRAD 3 both. Okay? This is a mixed cystic and solid papillary cancer. Now we move to a higher category. You see there are punctate echogenic foci, these white specks, punctate echogenic foci. And the nodule received also, it has a lobulated solid mural component, this one, okay? And it has also received 1 point for composition and another point for its isoechoic solid component. This component here is isoechoic to the rest of the thyroid gland. And 3 points for the punctate echogenic foci. So the total is 5. So here we are confronted with a TIRAD 4 thyroid nodule. Okay, and this is suspicious. Okay. Now here, you see the arrows are pointing at a 2 centimeter papillary carcinoma. There is marked hypoechogenicity. This is the thyroid. Compare the echogenicity of the thyroid to the echogenicity of the nodule to the echogenicity of the thyroid. You see, it is more black, yani hypoechogenic, hypoechoic. خلاص? The nodule also received 2 points for solid composition and 3 for marked hypoechogenicity. So the total is 5 points. Yani again, this is a TIRAD 4. Okay. Now this is another papillary carcinoma, a nodule that turned out to be a papillary carcinoma. The distinguishing feature or the striking feature here is that the nodule is taller, more tall than wide. Yani if you measure the anteroposterior diameter and compare it to the transverse diameter of the nodule, you will find that the anteroposterior diameter is larger than the transverse diameter. Okay. In addition, yani for the shape, the nodule got 3 points. In addition, the nodule also got 2 points for the solid composition. It is solid. And 1 point for the being isoechoic. It has the same echogenicity as the rest of the thyroid. And it got also 3 points for numerous punctate, the white areas, numerous punctate echogenic foci. So it got a total of 9 points. So now it's above 7. 7 and more is TIRAD 5. Is it clear?
Yes.
Okay. And this is thyroid carcinoma. You see the nodule? The white arrows point at a nodule. It has irregular margins. You see, the margins are irregular. It is 2.2 centimeters in size. Okay. And this gets it, it has a lobulated margin, so it gets 2 points. And the nodule also received 2 points for having a solid composition. And another 2 points for being hypoechoic compared to the rest of the thyroid, with a total of 6 points, yani TIRAD 4. Now here, there is another ultrasound picture showing a 1.2 centimeter nodule with irregular margins. They are even speculated, yani they have like spikes, and they are, the irregular margin got it 2 points, and the nodule was also assigned 2 points for being solid in composition and 3 points for having very low echogenicity. You see, it appears more black than the rest of the thyroid nodule, the thyroid lobe, I mean. And it has inside, the white specks are punctate echogenic foci, giving it additional 3 points. So the total points are 10. 7 or more is TIRAD 5. Okay, is it clear?
دكتور منى هي الصورة
Yes.
اللي كان فيها كالسيفيكيشن
فيها ايه؟
هو الصورة اللي فاتت فيها كالسيفيكيشن. الصورة اللي فاتت فيها
دي
هي
النقط البيضاء the white specks دي. نعم.
بتبقى مع البابيلري بس ولا دي ساين للمالجنسي؟
لا ساين للمالجنسي، بس هنا it turned out أخذوا fine needle أو عملوا surgery ف it turns out that it is a papillary carcinoma. واخدة بالك؟
يعني مش أي كالسيفيكيشن تكون بابيلري، عشان بابيلري تقريبا كانت بتسكريت كالسيتونين حاجة كده، كان فيها
لا
كالسيوم.
لا 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 الكالسيتونين دي الميدالري كارسينوما. ميدالري كارسينوما secretes calcitonin. اوكي؟
سوري ده.
لا اوكي، أهلا وسهلا. طيب any other questions? Am I going too fast or is it clear now? I hope it's going to become clearer لما دكتورة مها when Dr. Maha is going to explain to you all about thyroid ultrasound. She's going even hopefully يعني to show you how a thyroid ultrasound is done on a real patient يعني hopefully. But I'm showing you the pictures so that because many of you when you are working and a patient brings you a thyroid ultrasound report, you read TIRAD 1, TIRAD 2, TIRAD 3 and so on, and you don't understand what TIRAD is. So now hopefully you understand better what the TIRAD classification is for thyroid nodules. Okay? طيب. Now let me show you another papillary carcinoma. Bulging the thyroid border. You see here the thyroid border, you see the surface is not smooth. The surface of the thyroid is not smooth. It's bulging here. So this is another sign. Here, actually, at surgery, no invasion was demonstrated, but here you can see that the border of the thyroid is bulging. So this nodule received 2 points for being solid, this one, the whole nodule. Another 2 points for being hypoechogenic. This is the rest of the thyroid gland. And this nodule appears more black than the thyroid. For 3 points for being taller, more tall than white, okay? And 2 points for being lobulated, for having a lobulated margin. So the total of points was 9, bringing it into the TIRAD 5 classification. Is it clear? Is it clear now?
Yes.
Now again to show you the punctate echogenic foci in a papillary carcinoma. In this picture, ultrasound picture shows small comet tail artifacts. يعني ايه comet؟ comet اللي هو زي اللي هو بيسموه ايه؟ الشهاب. عارفين الشهاب عامل ازاي؟ Like there is a star and it has a tail. The same appears here, you see? This is the calcification, and as if the calcification has a tail. This is what we call comet tail artifact. And there are also small punctate echogenic foci, the white areas, okay? And in addition, it got 3 points for the punctate echogenic foci, but the nodule was assigned also 2 points for being solid. You see, it's not cystic, it's solid. And an additional 2 points for being hypoechogenic. This is the rest of the thyroid lobe. You see, it appears more black than the thyroid lobe. And it has a lobulated margin. If you look closely, it has a lobulated margin, so it got another 2 points. So the total, if you add 2 and 2, 4 and 3, 7, and 2, 9. 9 points. So it brings it into the TIRAD 5. Okay? So this is how you should report properly an ultrasound, thyroid ultrasound of a nodule. You need to state the nodule number, 1 or more, the location, where is it, left upper, the composition, whether solid or cystic or mixed, echogenicity, whether it is isoechoic, hypo or hyperechoic, the shape, whether it is wider than tall or taller than wide, the margin, whether it is smooth or lobulated, and presence of echogenic foci, whether there are peripheral calcifications or macro calcifications or punctate echogenic foci, and of course the size, 3-dimensional, 1.2 by 1.1 by 0.9 centimeters. This got it total points of 6, and it brings it into the TIRAD 4 classification. Okay. Now coming to thyroid scintigraphy, خلاص, the last thing we're going to discuss today. This is how it looks like. The normal thyroid gland has an even uptake of the radiotracer. The radiotracer used can be radioactive iodine, or it can be technetium-99, and so on. Okay. So in the normal, you need to know the normal uptake, how it looks like visually. But there is a percentage, a normal percentage. It's written in of course, in the report of the scintigraphy. In Graves' disease, there is diffuse increased uptake. It appears more black. Why? Because it has taken up more radiotracer than normal. So this is diffuse uptake in Graves' disease. In toxic multinodular goiter, only the hot nodules or the toxic nodules take up excessive tracer, while the rest of the thyroid is suppressed. You see, it's less than normal. This is how it looks like, the scintigraphy in thyroid toxic nodular goiter. How about a single toxic nodule? You see, only the nodule concentrates the radioactive material, like in Graves' disease, but it's located to the nodule only, while the uptake of the rest of the thyroid is normal or less than normal, because the hot nodule is autonomously functioning. While suppose it is a cold nodule may be carcinoma or maybe a cyst. You can distinguish by doing thyroid ultrasound. But on thyroid scintigraphy, both of them will appear the same. There is no uptake of radiotracer in the nodule, while the uptake of the radiotracer in the rest of the thyroid is normal. Okay. Now coming to thyroiditis, this is very important. Always remember this. In all types of thyroiditis, there is decreased uptake of the radiotracer. Okay? Is it clear? Any problems? So we have finished for today. I hope it was clear. Any questions? Anything that is not clear?
Thank you.
Type. I have like last time. I have put in the chat. I will put it again. The survey for today's session. Can you see it? I put it in the chat. Can you see it? Is it visible? Can you see it, ya Jama'a? Huh?
Yes, doctor.
All of you, even those who have guest accounts? Type. It's like last time, the same questions, very simple. You see, The second revision session added much to my knowledge and clinical skills. The timing of the session was appropriate. The discussion added much to my knowledge and clinical skills. Microsoft Teams is easy to use. The sound quality was good. Overall, how satisfied are you with the webinar? What did you like most about the webinar? What would you like? What would you suggest to improve the webinar? And of course, once nobody has answered, 0 responses. Once you start responding, the numbers will start showing up. Now we are 11 students with me, so I expect to find 11 responses, please. Okay? So please hurry up because I'm sure all of us are very tired today. And also, please tell me if you like a further revision session next time. We still have to revise the parathyroid diseases and the adrenals. Maybe we need 2 more sessions. So depending on your time, you just tell me when if you would like to have 2 more revision sessions, yes or no, and when you would like to hold them. It's up to you. You tell me. In the meantime, please fill out the survey. I won't go anywhere until you finish doing the survey. And please, like last time, those of you who finished the survey, please keep with us, stay with us, because it's always nice to know what other people think. You know what you have written personally, but it's always nice to see what other people think. Okay? Yeah. Did all of you manage to access the survey? Please answer me, particularly those with guest accounts, because sometimes students with guest accounts are not able to see the chat. Did all of you manage to open the survey?
Yes, Doctor, yes.
Okay, fine. Fine. I'm waiting for the responses. It doesn't take that much time, by the way. In the meantime, is there anything that is not clear? Is there anything that is not clear? Any problems, any queries, anything you want me to explain again? Yeah, 9 more students to go. As I mentioned, Yani, you can write whatever you wish, Yani. Feel free. I'm open to any suggestions, to any comments, to any critique. Can you please hurry up? I'm sure all of us are very tired by now. Aye. Okay. Okay, 5 more students to go. Yalla, would you hurry up, please? Yalla, what's it taking you so long? Yalla, 4 more students to go. Yalla, hurry up, please. Hurry up. Can you still see my my screen?
Yes.
Okay. Yalla, hurry up, please. Please. What's taking you so long? Did anybody have problems opening the survey? Or even finding it? Why are you taking so long to answer? Come on. You haven't got all night. Four don't want to answer the survey or what? Where are the 4 remaining students? Anyway, until they decide to join us in the survey, the second revision session added much to my knowledge and clinical skills. 85.7% strongly agree, 14.3% agree. The timing of the session was appropriate. 42.9% agree, 28.6% strongly agree, 28.6% disagree. These are 2. The discussion added much to my knowledge and clinical skills. 71.4% strongly agree, 28.6% agree. Microsoft Teams is easy to use. 71.4% strongly agree, 28.6% agree. The sound quality was good. 71.4% strongly agree, 28.6% agree. Overall, how satisfied are you with the webinar? 85.7% very satisfied, 14.3% satisfied. What did you like most about the webinar? It is excellent. The discussion to get answers, explanation was detailed, interaction, fast and easy, the variety of cases, discussions, and explanations. What would you suggest to improve the webinar? Nothing. It is excellent. Probably shorten the duration to not more than 2 hours. Yes, I would do that very much, but I would like very much to do that, but you're not helping me out with the rapid reply. Whenever I pose a question, you take a long, very long time to interact. So this is what why we're losing a lot of time. Yeah, it was very good. Nothing. And I think it is very bad that 4 of you refused to answer the survey. I wonder why. So you just tell me if you like to have another webinar, revision session next Sunday, inshallah, Sunday evening. We can do it. But next week, inshallah, maybe we will be able to cover only parathyroid diseases, because I'm going to discuss hyperparathyroidism and hypoparathyroidism with the imaging and the videos to show you the signs. But then we will be left with a big chunk of adrenal diseases. This includes Cushing's syndrome, Addison's disease, pheochromocytoma, and Conn's disease. So I don't know if you would like to have a 4th revision session or not. So you just agree together and inform me through Dr. Ahmed Ali. Another thing I want to tell you is that I'm going to put in the chat of this meeting, of today's meeting, the link of a video about thyroid gland examination. It's supposed to be on the faculty portal for the endocrine unit, but I'm not sure if it is activated or not. So just in case, I'm going to put the link of this video in the chat of today's meeting. Okay? Am I audible to you? You're certainly very silent, Yani. Okay. Did you fall asleep? I hope not.
Yes.
Okay.
I sleep.
I have been working since very early today morning, and I didn't sleep enough yesterday, so I'm really exhausted, yani. But for you, I'd do anything. Anyway, thank you very much for your patience and for your interaction with me.
Thank you for your efforts, Doctor.
You're most welcome. And I hope you let me know if you want a third and a fourth revision session or not. All right? And at what time? Because I heard from Dr. Ahmed Aleh that you didn't, not all of you voted on WhatsApp group. Not all of you voted. Okay, you're most welcome, Dr. Aleh. Tamam. Okay. Thank you very much, and I wish you restful sleep. Assalamu alaikum wa rahmatullahi wa barakatuh. You're most welcome, Dr. Farouk. تصبحوا على خير. Good night and happy dreams.
Thank you, Doctor. Good night.
You're most welcome.